innovation and contributing to higher productivity and economic output, we systematically must prepare for and tap into huge global market. Distinguished guests, the EAC region has an opportunity for growth in health sector, well-being through risk pooling, remote patient monitoring, telehealth, advanced genomics, better disease management, electronic medical records, better maternal and child health care, training, and low-cost surgery. Apparently, these aspects were exhaustively discussed and agreed upon during 2019 AU-ALM, where African heads of state and government agreed on 10 commitments, signifying the effective investment in these areas that require responsive policy reforms for the expansion of domestic allocated resources for health, strengthening health sector efficiency, improving the quality of service, financial risk protection, equity, strong functional multi-sectoral collaboration of the private sector partnership. Ladies and gentlemen, as EAC Secretariat, we are tasked with advanced and tracking 10 ALM commitments and reporting back to AU heads of state and the government on the progress made by each partner state. I must admit this meeting is confirmation of the national dialogues on health financing in country are critical enablers to sustainably meeting domestic health financing commitments through consensus, capacity building, and inclusive forums by all stakeholders. EAC looks forward to scaling up the same dialogue in the remaining 5 partner states. However, given recent financial trends and the likely trajectories for donor and government spending in health, all partner states in the EAC region have a critical role to play to chain the processes that evaluate in full and effective implementation of universal health agenda in the face of finite resources. This meeting, therefore, is important not only for the government of the Republic of Rwanda, but for all partner states. And we would like to commend His Excellency for championing this. And now this, for East Africa, this is the second country. And we are remaining with the 5. I know the rest of the 5 remaining partner states, they are going to follow a good example of Republic of Rwanda in financing health facilities. I would like now, after talking for quite some time, I would like now to reiterate the commitment of the EAC to the partner states towards the implementation of Article 1.8, which is talking about health in the East African community. I thank you so much for your kind attention, and sorry for a long presentation.
Let's appreciate Dr. Irene one more time. Dr. Irene, with the permission of our guest of honor, I think there's no need to apologize. You traveled all the way, and we're happy to hear all the beautiful words and the remarks that you've made here. In the culture of Rwanda for gifting, I almost gifted you a new name. So I want to apologize, and it is Dr. Irene. I know as you leave, you'll get some gifts, but that one, leave it behind. I want us now to move on to the next remarks that we'll be able to have on the area of sustaining the HIV response through financing and investment in Africa's health system. And on this one, I would like to bring on a stage the director of the Joint UN Program on HIV and AIDS, UNAIDS, and of course, she's none other than Anne Githuku Shongwe. She supports the team for Eastern and Southern Africa. Let's appreciate her one more time.
Good morning, and thank you so much for your invitation. Your Excellency, Honorable Minister of State, Dr. Ivan Butera, thank you so much for the invitation to be here. I also want to say thank you to all those from the government of Rwanda, others who are present from within the government, from the ministry and elsewhere within the government, also recognizing my colleagues representatives of the African Union Commission and the African Development Agency. My brother Samir, thank you so much for your comments. I will cut back some of what I intended to say just to make sure that I don't duplicate so much. My sister, Dr. Irene Isaka from EAC, we have been working well together with you and we appreciate the partnership. I also want to recognize our representatives of all development partners who are in the room, the Global Fund, who have been very, very strong partners, Calypso and other colleagues who are in the room, wonderful to be together. US government, who works very closely with us all the time, as well as others from the United Nations. I have our director from UNAIDS office here, Hind Hassan, who leads our team in Rwanda, as well as the World Bank, who are present, just recognizing all of you. I also know we have private sector partners, civil society and NGOs, academia. I just want to recognize you and others who are in the room. This July, Your Excellency, UNAIDS launched a global report that we titled The Path to End AIDS. And we said in this report that the path to end AIDS, we know it. There is a very clear path. And those countries that have followed that path have seen great results. Rwanda happens to be one of those top countries that were recognized this year and acknowledged as the countries that have followed this path very closely and does just 4 things that make sure that we can actually end the AIDS epidemic. The first is that we follow the data, we follow the evidence. So we're not shooting in the dark, we're following the data, we're following the evidence. That we're tackling inequalities because these are holding us back from what it is we think we can achieve. Investing in community systems that are health systems and beyond. What are our community organizations and civil society organizations doing to extend our services? And ultimately, that we sustain our investments, not just for today, but we invest beyond 2030 itself, because people living with HIV will be with us for a long time to come. So let me congratulate you and all those countries that followed that path and are doing very, very well. But indeed, as we follow that data and we look at the performance in our region, and when I say our region, I mean our region of East and Southern Africa, but also Africa, Sub-Saharan Africa as a region, 67% of all people living with HIV live in our region. 20 million people in our region, out of 34 million in the world, are here. And so even as we have had great success, and we've put many people on treatment, 16 million or so are on treatment, we still have many who are not on treatment, and every year we're adding more because we have new infections. Just amongst our young people, every day we say from our data at UNAIDS that we have 3,100 new girls infected every week in our region. 3,100. So by the time we leave here this week, 3,100 new infections. So even as we target and invest in those who are already infected and those who are already on treatment, the numbers grow. And so we cannot put the pedal off the brakes quite yet. We still have to keep pushing to make sure that we cover all those, particularly those who are infected, young people who are getting infected more and more, are those who are population groups that are most economically vulnerable, whose education outcomes tend to be weak, who have limited access to all services, including sexual and reproductive services. These are still some of the factors that we have to pay attention to across our region and our country. So how do we sustain the AIDS financing investments? There are 3 buckets that we talk of in financing that are necessary for us to ensure that we not just sustain the response, but we're able to go beyond our 2030 target. The first one is domestic resources. First of all, let me again commend Rwanda as a beacon of hope, because across your health investments, you are leading at 15.8% in terms of your health spend. And we really want to acknowledge that, because many of our other countries are still lagging at about 5%, between 5 to 10%. And so, again, you're a beacon of hope for us, and we use that as a light for many of our countries. But in terms of the HIV response, it's a very mixed bag. Some countries, barely 1% investment in their HIV response. And I think, sometimes I struggle. I'm with the UN, but I'm also an African, and so I have to ask myself the question, how is it that we continue to be okay with a 1% investment from ourselves and 99% investment from others? This is not the case for Rwanda, but I'm just sharing this for many of our countries as we talk about the region. So the investment in domestic resources varies from 1% to up to 70% in some of our higher middle income countries, Botswana, South Africa, who are close to 70%. But what we see is that where governments themselves invest significantly in the AIDS response, we see significant results. Where governments invest less, it's a big struggle. Because obviously you then can dictate and determine where these resources are going, what it is that you're investing in, how it is you're investing. And so national responses that are adequately resourced, that have adopted sound policies and made prevention and treatment technologies widely available, have demonstrated remarkable resilience and impact. So that's one big bucket that we call the domestic resources. The second bucket is international investments. We see a strong matching, again, as I said, with domestic investments, but we really want to acknowledge the role that our investment partners, the Global Fund who are here with us, the US government, who have made significant investments in our countries. And we want to invite them and really commend that we continue this journey together. And that where there is stronger investments there, we're able to make much more bold decisions. The health systems that we leveraged during COVID, and we have examples and we're building these stories of how the health systems built by HIV or through HIV or because of HIV with our international partners and our domestic resources made the difference for our COVID responses. Just recently across the border in Uganda, we had Ebola, a big threat of Ebola. And the systems that were used immediately were the systems for HIV, both community and health systems, and they were able to arrest the spread of Ebola very, very quickly because of leveraging those systems that we have built with both international and our domestic resources. And so being able to sustain and continue, and I know Calypso, you're in the room, many have been concerned that are we seeing a pullback of resources by our international partners? In fact, no. What we are seeing is that we are increasing, not increasing, but we're continuing to sustain the investments that international partners are bringing on the table, and we call on the continued investment by the US government that we need to help us to get to the finishing line, that will help us to continue to really reach the targets that we want to reach. We still have 4 million people who are not yet on AIDS treatment. We still have new numbers of new infections that are emerging. We need the US government, we need the Global Fund, we need our other international partners to continue to work with us on this journey and complement our own growing domestic resources. The third bucket, which is also largely private, but also has partnerships with international, is private and the private sector. This third bucket of financing, and again, Rwanda, we congratulate you for pioneering the health insurance levy. It's a big opportunity to raise your own resources from the private sector. We've seen this happen in Uganda. We're seeing this happening in Kenya. It's growing. South Africa has been having this big debate about how to increase and enhance the national health insurance system to be able to fund the health response and health systems. We see this as a growing model and an important one. So those who are in the room from the private sector, we really want to continue on this investment. However, we remain heavily dependent. And for us who are in this HIV and AIDS response, less than 2% of the vaccines, as my sister Irene was saying just now, come from our own domestic resources. Less than 15% of ARVs come from our own domestic resources, and of all other essential medicines are below 25%. So it is really a massive opportunity for the private sector to hold our hands in looking at how to increase our local production, to enhance this big opportunity that we have, so that we can stretch these resources, both domestic and international, at a level that is lower than what we have now. At $100 on average per person per year, maybe a bit less than that, of our ARVs, it's costing us, or would potentially costing us, $2 billion to be able to sustain AIDS per year. This is a huge, huge, huge number. And local production, with all the regional arrangements that are being made through these regional financing hubs, present an incredible opportunity. So in conclusion, ensuring the sustainability of the AIDS response requires for us a robust and well-financed health system. It means that we include the full inclusion of the health dimensions of the AIDS response in universal health coverage. This is mission critical, and it's important that we sustain this and that we look at how we continue to build out the strongest health systems possible. This dialogue is a big, big expression of your political and financial commitment to ensure the strong alignment and investment in these health systems. Ensuring growing investments in prevention and integrating community systems continues to be an opportunity that will help us to go beyond 2030. Finally, the sustainability of the AIDS response and the issue of prevention that I have raised, and I'll keep emphasizing prevention, 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 so that we don't grow these numbers, happens beyond the health system. So, Your Excellency, we need the partnerships with education, with social protection, with gender, with other parts of our system to help us to ensure the protection, the prevention that is needed to keep the numbers down. We congratulate Rwanda and all the partners, the ALM, and those who are preparing for the Kigali summit that will help us to push further with our heads of state, and that will enable us to focus on not just sustaining the response by 2030, but even beyond that. Thank you.
Murakoze cyane. Let's appreciate her one more time. Thank you. Thank you for bringing out those thought-provoking numbers. In the room, anyone from private sector? Just raise your hand up. Yeah, we need to talk Mujikari. Less than 25% local investment. We need to talk. And maybe that's why we are here. Save Joe? That's why we are here. All right, so we keep simmering on this statements that we're hearing here, because later on afterwards, we'll have a reflection session. If you have any questions, just note them down. If you have some points that you'd like to raise from the presentations and remarks you're hearing here, we'll have that session in just a bit for us to be able to reflect on the statements and the numbers that we're hearing today. At this point, I want us now to hear on the overview of the healthcare financing here in Rwanda. I know we've had some statements, and of course, to give us a deeper overview of this, I want us to bring one more time the head of planning, strategic information and health financing at the Ministry of Health, none other than Dr. Mohamed Semakula. Let's appreciate him as he comes for this presentation. Can we give him more energy? He says he's not coming until you clap properly.
Well, thank you very much for having this opportunity of presenting overview of health financing in Rwanda. In fact, there is much ongoing in terms of increasing domestic resources here in Rwanda. So, and I want to share with you some of them. A second, I can put my glasses. Great. So overview of health financing in Rwanda, and this slide is going to be just to give you a little bit of brief. I will talk about the country context, key health financing indicators, and then also I will try to align ARM reform objectives with our national health financing strategy, but also see the progress of Rwanda in line with ALM objectives. And then, as I said, we have had a 2-day session with experts prior to this dialogue to identify the key area and the focus for the health financing sector here in Rwanda. So therefore, I will show you those areas that will be discussed today by experts in each area through the panel. But by just going through the background, giving you the context, as most of you know, our GDP growth is about 8.2%, and this is from 2015 to 20, slight before the COVID pandemic. But also, the driver of our growth was more the public investment, capital accumulation, revenue from tourism services, and agriculture. When you look on the public expenditures, where we're talking about 28 GDP, including the health. This one informs us, given that we are seeing our population growth of around 2.3 annually, and the increase in health demand, especially through the fact that almost above 90% of Rwandan citizens, they have health insurance, that's also enable people to demand for the health services and so on. But also we have seen an unpredictable, sometimes unsustainable external financing according to the data that we are having over time. We are seeing a big change in terms of disease pattern. As Honorable Minister of State said, we are having a dual burden of disease. And this is what's reflected. We appreciated that our life expectancy increased to 70 years, but also we are seeing the mortality rate increasing due to non-communicable disease, surpassing the infectious disease. And remember that most of our system were more structured to handle non-infectious disease, especially here in Rwanda, where we are having a community health workers that were more confident and prepared to tackle infectious disease. Currently, we are seeing non-communicable disease increasing, which also means that our system has to adapt to the current pandemic pattern that we are seeing. When you come back on the key health financing indicator, when you just look on the trend of total health expenditure per capita, we are having about 68. But this one means what? You can see that from 2016 up to 21, in the last 5 years, that's GDP, that trend of per capita is defined by the 3 sources, where we're having public total health expenditure, private, as well as external. If you look on that graph, it's obviously clear that there is an increase from the government investment in total health expenditure, but also we are seeing, and that's increase, remember from 2016, we had 26, and currently we are about to 36 of increase. But when you look on the external funding, it's also reducing from 49 to 39 currently, slightly. But we are seeing another sector that we want to involve, mainly, which is the private sector. It did not change much in the last 5 years in terms of their total health expenditure. They are still on 25% contribution. And that's why in this dialogue, we thought it's important to focus more on how the private sector also can play a bigger role in health investment. I don't want to talk much about the background of ALM because the previous presenters talked about that one. But the most important, you know, that His Excellency President Paul Kagame was appointed as AU leader for the health financing. And this one resulted of the 5 African regional health financing hubs, as well as the dialogue that we are having now as a strategy to discuss on how can we increase our domestic resources. So there's these 4 objectives. One is mobilizing more money for health. And second is more health for money and the equity, and then the leadership and the coordination. This one I want to discuss it by aligning with our strategy. As Rwanda also adopted, being that His Excellency also championed, our health financing strategies is fully aligned with objective of ALM. And that's what you are seeing. Our objective, our strategy 1 and strategy 7 are literally translating from the mobilize more money for health in our financial strategy. The same, each objective is aligned in order to ensure that we are implementing ALM as recommended by head of states. Evaluating on how we are doing in terms of progress, we are seeing there are some of key indicators that we have, and those indicators are also aligned with ALM objective. And we want just to see those indicators vis-a-vis on how Rwanda is doing. In terms of raising resources, you can see the share in terms of tax to the GDP. There was a little increase, but due to the pandemic and the other factors, we kind of reduced it a little bit from 16 to 15.7, which is understandable due to the COVID and the other factors that came with that one. Most of business were not working during that period, and therefore people were not even paying tax. Then there's also allocation. When you look on allocation, especially on domestic expenditure, taking into consideration the government and the private, we are seeing that there is an increase. We are now about 61% from 58% in 2019-20. So there is this increase that is there. When you look also on capacity of observation, we are seeing that all the budgets is nearly consumed as planned. Then if you look on those indicators, looking especially on the efficiency itself, you can see that Rwanda is participating in the pooling approach procurement in order to ensure that there is access to the medicine and the commodity, but also to the price that is affordable to ensure that our citizens they can access medicine. When you look on the effectiveness itself, we are seeing that Rwanda is investing almost 60% of the total public health spend is allocated to primary health care. This one is justified, as you know, in our reform, that Rwanda currently is looking to have 95% of all disease managed at a primary health care. Therefore, the investment also goes with that particular policy. When you look in terms of measuring and monitoring itself, this is justified the way we define our health benefit package, because it's defined by the demand and data itself in order to define the package, especially for those who are using community-based health insurance. Just to remind you that though above 90% of people who have health insurance, they are using this community-based health insurance. Therefore, changing the package, benefit package, and so on, it's mainly basing on those indicators, data-driven decision, and so on. In terms of monitoring, as we said, Rwanda is known for using this performance-based finance, and we do evaluate always to ensure that we achieve the goal, but the goal also are aligned with financial. And this one has proven improvement over time. Then when you look in terms of equity, just to remind you that before we had about in 2016, we had about 499 health facilities across the country. And until now, we managed to increase to 514. This is to ensure that people are accessing services and nearby their living areas. And then we added also another area, which is very close to the population, which is the health post. In 2016, we had 471, and currently we are having about 1,250. And from where someone lives, I mean, from the household to the health post, it doesn't take more than 30 minutes. It's below 30 minutes to access the health post. This is to ensure that people are accessing services in their neighborhood. When you look in terms of the equity in finance and risk protection, government is subsidizing especially the vulnerable groups in those for the community-based health insurance premium and so on, and the co-payment itself. But also you can see that the out-of-pocket is less than 5%. So this also translates on how people are able to access the services. Then in terms of leadership, I think the partners and people who are working in the health sector here, I don't have to talk more about this one, the way the coordination is done, because we are working hand in hand with our partners, with technical working groups and so on. Whatever decision and budgeting we do with all the stakeholders included. And then we have also the joint sector review and so on that's involve our partners. But also when we look in terms of satisfaction of citizens, in terms of the health services, the last scorecard from RGB, it shows that 85.2%, they are happy of the service that they are getting from the health services. So without taking much of time, I want just to identify the policy focus that were identified by experts. And those areas are the one defining the panels that we will have in this dialogue. One, it's on sustainable HIV financing. As the previous speaker talked about the issue of HIV sustainability, it's heavily funded by externals and so on. But also there is improving the private health sector engagement, as also you saw that in the last 5 years, they are not increasing, their participation is not increasing as expected to the health sector. So those are the areas. Another area is going to be on digital. How can we get efficiency through using the digital tools? And those are the panels that we are having. So we assume that with your expertise and contribution, we come up with a fruitful recommendation that can shape our strategy to increase domestic resources. Thank you very much for your attention.
We appreciate you, Dr. Mohammed. Thank you for that overview, at least to give us a better picture, bigger one, on the areas of focus that need some intervention and attention. I want us now to get ready to hear on a very important presentation again. And this one, I like it because it's not just going to end at giving us the current macroeconomic environment, but we're going to also hear some potential solutions. And I want us to put our hands together for the head of Health Financing Department at Global Fund. That's Dr. Calypso Chalkidu. Let's appreciate it. Appreciate it as it comes. More energy, please. More energy for her, please.
Thank you. Thank you very much. It's a pleasure to be here. I think I only have one slide, so give me a second to set myself up. Right, so first of all, thank you for having us. It's a great honor to be here. We've heard wonderful presentations so far from colleagues. Rwanda has done an amazing job and is indeed a paradigm, an exemplar for all of us in how we can approach this problem of HIV, TB, malaria that we're tackling, but at the same time strengthening health systems, protecting the poorest, the most vulnerable. And we've seen the numbers that speak for themselves. So it's a great privilege and a great honor to be here with you today. So I've only got one slide, but I've got a few things to say on that slide. It's quite busy, so bear with me. First of all, I think it's fair to say, and we're all on the same page on this, that the continent and the broader world is faced with the macroeconomic headwinds right now. Things are not easy, and perhaps fair to say that things will get even worse before they get better. We know that domestic financing for health is right at the heart of sustainable financing for health in general, and it's not an optional extra. We've seen this, we've talked about the external contributions, but also the importance of domestic financing, the importance of building on domestic financing, domestically here in Rwanda, but also as in the context of the ALM priorities. So the arguments to invest more, invest better for health are there, but the times are difficult, the times are hard. And especially for us, the Global Fund, as our colleague said earlier, we're very much committed to working with you, to investing in Africa, to working together here in Africa. Over 70% of Global Fund investments are located here in Africa, and this will almost certainly continue to be the case. But the macroeconomic environment is quite challenging. Now, Rwanda is yet another exception, perhaps. You saw the growth figures, 6.8% in 22, and projections of about 7.5% in 2024, according to the latest outlook by the IMF. But if you compare this to the broader sub-Saharan African region, where the growth has been 3.9% for 22 and is projected to grow to a bit over 4% in 24, the situation doesn't look as good as certainly it did look before COVID hit us all. At the same time, we have serious issues with debt and inflation. Public debt, public indebtedness in Africa is nearing multi-decade highs. There's 38 countries in sub-Saharan Africa that are high risk or are already in debt distress overall, and 19 of those are in sub-Saharan Africa. 1/3 of countries in the region now have public debt levels that are above 70% of GDP. Now that's critically important because debt and debt servicing, given the high inflation as well, eats into the ability of governments to invest in health, to invest in education, to invest in public causes. And it's also unfortunate that the outlook is not as good. We can see that the burden of debt and debt servicing is not likely to reduce soon, so things will probably not improve. And by 2025, the IMF projects that over 20% of government revenue will be going to service debt. That's a huge number. In many countries already, debt servicing is way above what countries can afford to spend in health. And this was even before COVID hit, and unfortunately the stats will probably get worse in the near future. Now, the context is indeed extremely challenging, and it is in this context that we must continue making strong and convincing arguments to continue investing domestic resources in health in order to sustain the gains we've made over the past 20 years. I'd like to take a few moments perhaps to reflect not only on the challenges, but also some of the approaches that we at the Global Fund are taking in partnership with you to address those challenges, because ultimately I think we have to be positive and optimistic in order to achieve our objectives. So what do we do at the Global Fund? The Global Fund is adopting a multi-pronged approach to supporting domestic financing for health across the countries we work in. We appreciate that countries have to be in the driving seat. It's your remit, it's your money, it's your decision. All we can do is support as best we can, complement your efforts, and follow your leadership. And how do we do this? Well, through quality technical assistance, through capacity building where we can do that, through working together with partners in country and globally to make the case for domestic investment. So a few things under the more money for health agenda. We work on blended finance, and we call blended finance the blending of our grant resources with loans. And this is important. It's important because it reduces the interest effectively on loans in those countries that borrow even when it's concessional, it increases this concessionality. And when it's IDA credits, for instance, again, it helps improve efficiencies by aligning our resources with those of the likes of the World Bank and multilateral development banks. It's important to say that we do this not to replace grants, but to complement our traditional grants. Money is scarce. However hard we try, I think ultimately we must make sure that the money goes further, and this can only happen when those who finance health, domestically and internationally, publicly and privately, work together. And I think the current conversations on refreshing and changing the global financing architecture really reflect the need for partnerships. Our work focuses on a subset of countries where there's potential for impact and favorable conditions for lending. We intend to crowd in resources without crowding out domestic resources. We help raising additional resources and or also influencing existing resources in support of the 3 diseases and health system strengthening. So this is an opportunity for us. At the same time, we work closely with governments, sovereign governments, on debt to health swaps. So far, debt to health swaps have focused on bilateral deals between governments. They're basically, this approach allows creditor and debtor countries to convert, to swap part of their debt into life-saving health investments. And this is an opportunity we're honored to be able to catalyze and support when the debtor and the creditor country can come together. And we've done this in several countries, and over the last few years, this has leveraged about $220 million in 10 countries. So it's not a huge amount of money, but as a modality, I think it's really important. And it's now becoming all the more important given the current climate and the debt issue I flagged earlier. We also work on value for money. This is more health for the money. I think it's absolutely critical that we spend efficiently. We cannot afford waste given the scarcity of resources and the pressures on these limited resources that are available. We know that, for instance, African nations pay 30 to 40% more than international reference prices for essential drugs. And these are not just on patent drugs. These are drugs that have been off patent for a while, but somehow the marketplace for drugs on the continent doesn't allow competition to take effect and prices to be reduced. I used to work in the British National Health Service, including on negotiating drug prices, and oftentimes we'd see that our National Health Service in the UK would get a better deal than some very poor countries in sub-Saharan Africa. So this is something that needs to be addressed. There's absolutely no reason or limited reason that this is the case. So we think it's an opportunity for quick wins, including promoting pooled procurement to ensure best prices for quality-assured drugs. And looking at priority setting, we saw how CBHI is reviewing its health benefits package, using health technology assessment and priority setting based on evidence. This is critically important to identify cost-effective opportunities for investment. And this will make also a stronger case when one talks to finance ministries for investing in health, because they can understand, they can see how efficient this investment can be in addition to being effective. Now, we align with national health systems. We work to help diagnose and address some of the roadblocks that prevent investing through national systems. 20% of agreed health budgets allocated do not translate into health expenditures. Rwanda, again, is an outlier, a positive outlier, and you see that absorption rates are high, but in general, absorption and ability to execute the allocated budget is limited. So strengthening public financial management systems is absolutely critical, and we're keen to work and are working with governments and, of course, with the likes of IMF, the World Bank, and others to contribute to this cause. And, of course, thirdly and importantly, political and domestic financing advocacy efforts. That's why we're here today having this dialogue. It's evidence-informed advocacy. It's a dialogue that's based on evidence of the past and of the future. And I think that's really powerful and really important. Having such high-level representation here today from the leadership of Rwanda is really an honor and extremely hopeful, I think, I am for looking at the future and what we can achieve working together. So we recognize that financing reform is very much entails strategic shift, longer-term strategic shift in policy, and it's political. Ultimately, it's a political decision. So it's important to build on the work that we've already initiated and worked together in support of the Africa Union's ALM initiative on domestic financing under the championship of His Excellency President Paul Kagame, and through the health financing hubs that are based in the regional economic communities. The potential is really significant there, and we want to help maximize that potential as best we can contribute under the leadership of the Africa Union. I want to acknowledge the support from the Gates Foundation. That's been absolutely critical for the implementation of the ALM, all the way from declaration to action. And we call upon other partners to support this endeavor. This is an important endeavor, it's a legitimate endeavor, and it's gaining immense momentum, and right now it's absolutely critical. It's a solution to many of the problems I cited earlier. So with that, I want to thank you for having us. Once more, I look forward to the panel conversation and, of course, to continuing to work together. Thank you very much.
Let's appreciate Dr. Calypso one more time. Thank you very much. Now, the stage is set. And of course, now we have a better overview on some of the things that we'll be discussing here. In fact, most of them, if not all. And so I want us now to go into a reflection or open discussion session. If you had any questions on any of the statements that were made here or the remarks, now would be your time to do that. And so I would like to call on the set here, on the panel, all the speakers that spoke earlier on, and I'll call them by name. So I'll start off by none other than Mr. Simere Gray-Johnson, the Director, Human Capital and Institutional Development at AUDA NEPAD, to just come here on the set. Let's appreciate him as he comes. I'll also call upon Dr. Irene Isaka, Director, Social Sectors, East African Community, to also join us right here. Let's appreciate her, please. And then I'll also like to invite Anne Githuku Shongwe, the Director of UNAIDS Regional Support Team for Eastern and Southern Africa. Let's appreciate her, please. And then we'll also have Dr. Mohamed Semakula, Head of Planning, Strategic Information and Health Financing at the Ministry of Health. And finally, from our last speaker just now, Dr. Calypso Chalkidu, Head of Health Financing, Department of Global Fund. We can do better, eh? We're going for a health break shortly, so yes. Let's use that energy. We finish it so we can replenish when we go for the health break. So if we have any questions, we have roving microphones. We also have a microphone on your table. So please feel free. If you have a question, if you have a comment, feedback, you can also specify to who you want to direct it to, and then we keep it as brief as possible. So let's do this. Just raise your hand up, and there'll be a mic to you, or you just switch it on, and then you introduce yourself, and then proceed. Or everything was clear?
Everything was clear.
Yeah? Was it?
Everything was fine.
Okay, let me break the ice. I'll ask. Because I love asking questions. So I think I would like to understand, probably first of all from Dr. Gray-Johnson. There's a statement you made, and I think I loved it. You said, there's a clear path. You're not shooting in the dark. And of course, I look back at the data, and I see that the new global AIDS strategy for 2021 to 2026 is saying that will require around 29 billion plus US dollars to be able to support in rolling back the cases or working on rolling back HIV and AIDS. And yet we hear of the 1%, we're clearing the less than 25% in local investment. What will we need to be able to get this financing taps flowing from the local financial institutions?
Okay, so you looked at me, but you mentioned
Okay,
Dr.
sorry.
Simere Gray-Johnson.
I think our eyes, people with glasses, eh? It's Go ahead, please. Yeah.
And you can start, then I can comment. Yeah.
Well, thank you so much. I think what we are saying is that we have seen that where countries have taken the leadership and the investment in health systems, and you know, what I appreciated about Dr. Mohamed's presentation is the emphasis of Rwanda's program on primary healthcare. And we were here during Women Deliver recently and visited your clinic. I have to remember the name, but it was about an hour's drive or so away. And what was impressive was to see how well integrated the services were. I mean, we went to see how young women and girls services have been provided, but we also recognized that in the same facility for health, they also had social services that are linked to violence against girls, but at the same time, there was treatment for children, and the facilities were so well organized that it was very clear that this is what we're talking about when we're talking about universal health care and universal health coverage. And so, in building these health systems and in investing in domestic resources, the intent is to ensure that we're leveraging the global resources that are coming into countries to establish sustainable health systems that can live beyond any external support that may come, and that can deal with the fact that today, as Dr. Mohamed shared again, we are seeing a real crisis, actually, of non-communicable diseases, when all along our focus was on infectious diseases. So I think what we need is to just continually focus on how we build the health system, investing on those systems ourselves, and not see HIV as a passing cloud. You know, this is an infection that will come and go. This is not Ebola. It's not passing us. It is an opportunity to build systems that can be leveraged across all diseases, but also will leverage other sectors. The better educated we are, the higher the chance of better health outcomes. The stronger our social protection, the same. So really the path to end AIDS is saying, build on the systems, recognize the inequalities, follow the data and evidence, and sustain this HIV investment long term.
Right, thank you. Dr. Rather, not doctor. I think I'm promoting you, yeah? You're one, yeah?
No, I'm not a doctor.
Oh, yeah, so already...
I'm going, I won't be one.
Manifesting, eh? I know I'll come to you, but before that, I want to hear from Dr. Calypso, just kindly. You know, when you're presenting or when you're speaking, Dr. Calypso, you mentioned several things that are giving us the clear picture that we are on today. There's the debt distress. We know we have global shocks in terms of the wars that we're seeing, and they're impacting even the financial flows into the continent. And you even mentioned, and I'll quote you, said, the status will get worse in the near future. But you still insisted that we can not remain pessimistic, we need to remain optimistic, and we need to also be positive. But I know you and I agree that nothing will happen with just those two things. Optimism and remaining positive. We need to do something about this. And I know someone might say, she's a prophet of doom. Why is she saying that things will remain worse like that? But you're right, it is the reality. So what do we do then? What do we do amidst all this big status that you said?
Thank you. Thank you. And I think, first of all, what we're doing currently here, right now, is really important. This is an action. These are commitments that in the past have led to the progress of experience that's evidence-based, and will continue to do that. I think the political commitment is the beginning and the end, really. It goes a long way towards actually making a reality this optimism. So it's not just empty words. We see the political commitment, and this translates into action. So that's the first thing to say, and it's not Rwanda alone, but also through the AU, the leadership across the continent. And we cannot overstate the importance of that political commitment under the leadership of the AU. So that's the first thing to say. The second thing to say is, as we've just heard, health is multisectoral, it's public, it's private, it's high-tech and low-tech. And COVID taught us this. Countries that traditionally never expected to suffer from an infectious disease did, and suffered badly, even worse than countries that were poorer and traditionally were the ones who had the higher burden of infectious diseases. We've seen how important it is to have a collaboration of public and private sector. We've seen how stronger health systems have helped countries, including community health workers, for instance, where the systems worked well at the community level. We've seen how technology matters, including high-tech. Again, we talk about primary healthcare, and this is very important, but at the same time, we've seen the need to invest in hospitals to have the oxygen supply, etc. So I think we need to think more broadly, and I think it would be really bad if we were to forget so quickly what COVID has taught us about the importance of health systems. It will really be detrimental. I mean, if we can see one good thing coming of a catastrophe, the catastrophe that COVID was for health and for the broader economy of the world, is to really understand that health systems matter. So going forward, we cannot give up, precisely because we've been through the crisis we have been through.
Yeah, we cannot give up. I think that's the word. That's the word. I see a hand up, so we'll take it. Say your name and institution, and then I'll come to. Yeah. Okay. Go ahead.
I think it's important that I add on to the momentum on health systems. So I want to make 2 quick points. First, the positives, and then the negatives. The past 5 years at the continental level, under the leadership of our chairperson, His Excellency Moussa Faki, is the period of which Africa set up the development agencies. So we had the African Union Development Agency, the AFCFTA. Then we transformed ACBF into a specialized agency that deals with capacity building. And then we have Africa CDC. And soon here in Kigali, AMA, the Africa Medicines Agency, will be established. So this is very, very positive.
Right.
Some 23 years ago, we only had 1 development agency called NEPAD. So now we have 5. Out of those 5, 4 of them somehow are dealing with health systems. AFCFTA, the top 3 priorities for the AFCFTA is on the pharmaceutical industry, manufacturing, and so forth. Secondly, of course, we have the CDC. Everyone knows what they've done, especially during the pandemic. And we're going to have AMA here. And AUD and NEPAD, we are reorganizing ourselves to look at investments, financing in the health system. So that's very, very, very positive. 2 days ago, we met with the committee of 33 heads of state, which is a committee of special advisors. These are ministers, senior officials, ambassadors of 33 countries. Of course, Rwanda used to chair our Heads of State and Government Orientation Committee, and they are part of it. And we sound the alarm bell of what my sister Anne has just said, and Doctor has just mentioned here. And we put the data up, and we showed that if we continue, look, every government has 100% in terms of their budget. So there's so much we can. We have cut up 10%, we have infrastructure 5%, of course 15% on health, and we can go on and on and on. We haven't talked about security, we haven't talked about everything that has to go to the budget. But we need to discuss decisively how do we sustain investments, especially domestic investments into our health sector. So we put up the negatives. 95% of our medicines are imported, and 99% of vaccines are imported. Africa only has about 336 manufacturing companies that can produce entry-level drugs, and also that we can't continue the way it is importing these drugs. So those are the negatives. And I think what we want to put through is that under the ALM, great work has taken place. How do we redouble our efforts, get more regional economic communities involved, more countries? We've just had so far 7 to 8 countries. We still, I mean, it's 55 countries. So the work ahead is very important. And I think this dialogue here in Rwanda has solidified the cookbook. Of course, it's not a all size fits all, but we have the cookbook. I think by tomorrow, we can flip the pages and arrive in Gambia or Niger and say, look, this is how Rwanda's doing it. We can do it this way. Because time is not on our side. So I needed to emphasize that this is a very important process. And we, of course, we encourage the dialogue.
Interesting. Wonderful. Let's open the floor now. I'll take a question there. Yes?
Thank you. Good morning. My name is Koech with UNAIDS. I think, Sameh, you've answered my question. I don't know whether you're reading my thoughts. But I have a question for Calypso. You say 30 to 40% unfair treatment for Africans in terms of vaccines and prices. And Anne just told us that we have 20 million people living with HIV in Africa that have to take a pill a day, which translates to 1.6 billion per month in terms of the ARV bill. The Global Fund supports majority of the procurement of ARVs in most of these countries together with PEPFAR. What do you think we can do? Because if we were to reduce this inequality, we would knock off about 600 million, which is a big figure. What leverage can the Global Fund and PEPFAR in terms of the price negotiations to reduce this and release some of this money for other things in the health sector? Thank you.
Yeah, you can take it.
Sure, thank you. Well, first of all, let me say that the figure I cited in terms of, if you like, markups over and above what other countries may be getting was not referring to ARVs. I think the ARVs market is quite competitive. Certainly the sort of first-line ARVs, the ARVs have been out there for a while. The unit costs have come down quite significantly. But this doesn't take away from your question that it is important. We're all spending significant amounts of money. And I think being able to work together, including through pooled procurement at national, regional level or global level, in our case we do a lot of that as well, is absolutely important. But ultimately it comes back to the points you've just made about local manufacturing. Local manufacturing requires a market. People will invest because they can see there's a predictable demand. They could probably see this for HIV because it's there, but for other medicines, I think it's yet to come in terms of being consolidated, being predictable, being to some extent guaranteed, because investors take a risk, right? It requires a regulatory framework that hopefully AMA will bring about further beyond, in addition to the efforts of NEPAD all these years. Because again, going through a regulatory process can be very expensive and time-consuming, and then it deters investors from stepping into this space. So all the things you mentioned, Africa CDC, the free trade zones, agreements, the regulatory agency to help harmonize and fast-track will help with what you're saying. And we stand ready to work with you throughout this and align ourselves with your efforts so that what we're doing really serves your priorities.
Interesting. I want a lady first, then I'll come to a gentleman. I saw a lady over there. Go ahead.
Thank you. I'm Florence Momana from Rwanda NCDs Alliance. I have a question addressed to Global Fund and UNAID. Based on the presentation of Dr. Mohammed, we have seen that NCDs is overtaking infectious disease. I would like to ask, what do you think about integration of NCDs and HIV services, especially when we are considering patients who may be having both HIV and non-communicable disease? Thank you.
Thank you.
Thank you so much. I really think that we are beginning to see this happening increasingly, and I just want to give the example of my, my own home country, Kenya, where the National AIDS Council now has this broadened name that includes HIV and non-communicable diseases, or what they're calling syndemic diseases. So this is expanding. It is something that we're recognizing. But I think ultimately, I'm back to my point about universal health coverage and about how we build the health systems. The time for parallel treatment, parallel programs is over, really. We have to be able to look at how to integrate services as strongly as possible. I think as we strengthen our own domestic investments and strengthen our own development of health systems and community health systems, that we have a higher chance of providing comprehensive integrated services. I think the difference we would have is in the financing of it. If you have financing that is coming from different pools, and how do you direct that financing so that it also captures the different multiple diseases. And I think Global Fund is a good example, who are in every Global Fund proposal, we have to look at multiple diseases and not just one. So this is something that really is critical for us. It's increasing. People living with HIV are living for 30 years, and many of them are now having to take both HIV treatment and dealing with non-communicable diseases. So that is happening more and more. And it is something that we are supporting and working with our partners. I see my colleague from WHO is in the room, and I'm sure he'll say something about this, but it is a work that we're doing now collectively to ensure that we are more comprehensive in our response.
Yeah. All right. One last one, and then we can move. There was a hand, the gentleman. Yeah, go ahead.
Yes, thank you very much. Thank you to the presenters. My name is Dr. Brian Chirombo. I'm the WHO representative to Rwanda. Excellent presentations from the panel. I want to just pick up on what Dr. Calypso mentioned, the issue of learning from the COVID pandemic, ensuring that we prioritize building resilient health systems. I think it's something that we have to keep building on. But as we do that, I think we need to also think more about the reinvigorating universal health coverage, which we have talked about, which WHO has been working on as a way of achieving, because that's really the best way of achieving universal health coverage, as we have seen from the example from Rwanda. I think my question goes to Dr. Simea. Because as we talk of primary health care, one of the challenges we have had, Rwanda I think has done better, but in many of the countries we struggle to make sure that we engage all the sectors. It's not health. Yes, community health workers, yes, but it needs to go well beyond health. So I wanted to find out from the AU, what are the initiatives, what are we doing to ensure that we assist with bringing in the other sectors to ensure that as we reinvigorate primary health care, we involve all these other sectors. Of course, we've already talked about ensuring that we have domestic funding for it. We have the example of Rwanda, and I know you are talking about that. But I think we need to bring in all the other sectors. Everybody has to come to the table. Otherwise, we'll keep talking a lot about reinvigorating primary health care. We keep focusing only on the health sector. And we're not going to make the progress that we need to actually make to be able to do that. Thank you.
Dr. Chirombo wants action. There's been a lot of talk.
Yes, indeed. We definitely need action. And I'm going to answer that question using a different initiative that we are pushing. And Doctor, you will know that in Gaborone, during the meetings, we had a side event on neglected tropical diseases, and we found out that only 4 African countries do budget for it because perhaps it's not being seen as something of a threat. But it has been brought to our attention through the work we're doing on education, the amount of children that are affected by NDTs. So again, it comes to the question you are posing. It's not only about the health sector. We have to look at it holistically. Education plays a role. So that it was the education ministry that really put forward, that sounded the alarm bells, that we need to revisit the NDTs and how it's affecting these 33 African countries and how children are being affected by the diseases on the NDTs. So that's one point. The second point is, I think through the ALM, we should be able to have a platform that will allow us not only to push through the same conversations on the need for investments and financing, but to also bring in the relevant players within any setup of a government. For example, I think if we do this properly, and we are doing it right, we're on the right path, we should be able to come up with a very solid platform that allows ministries of finance, also other stakeholders, together with other partners and MDBs and so forth, to look at precisely how the ALM process could allow countries that have gone through the process to bring up investable projects and programs that we can look at. And I think that's the direction we should take. And I think we're on the right path here in Rwanda. By tomorrow, if we continue this dialogue, I have no doubt that we should be able to say that, look, we have these very well thought through projects and programs that the private sector should be interested in, but how do we galvanize support to bring in more investments? And for those projects that need financing, how do we do the financing? How do we look at other forms of financing, innovative financing? But it has to be a platform that brings together not only the sector ministries, but the ministries of finance and other players, including, of course, the regional development banks, TDB, and other banks that are in the region. So I think the point is very clear. From the African Union Agency, African Union Development Agency, we are not looking at it as a sector approach. We're looking at it a multifaceted approach with all the necessary players. And I think we need to continue this discussion and build that platform that will allow member states to bring in investable projects that we can really invest in and finance.
Right.
Thank you.
Thank you. I want us to finish off with one question for both Dr. Mohammed and Dr. Irene. Just to get your perspective from where you sit, why or what is your biggest challenge in mobilizing local resources? Where is the headache? What's the missing link? Why do you feel private sector is not coming fully to the party?
Yeah, thank you very much. That's a good question, and I think that's why we are here with private sector. Today we're going to discuss on their involvement through different panels, but also I think we have also a special session for private sector in the evening, Garadina, showing them the opportunities that are available in health sector. I feel like most of the problem, maybe there was an awareness of what they can do in terms of investing in health sector, because sometimes people, when they talk about health sector, you're only seeing hospitals, you're only seeing problems, but there's also opportunity in terms of manufacturing. Yeah. There is also opportunities of public-private partnership in order to access. This example that we have done with on the health post, I said we have increased our health post to 1,200 and above, but I want to mention that it was also through private-public partnership, because in some cases the government put their infrastructure, and then they give management of that health post to the private sector and so on. And that's one who has managed to boost the access to the services and increasing of the health posts across the country. So I think the most important is having discussion and showing the opportunity. The private sector, of course, they want to invest, they want to see the benefit, but still you can make benefit and save lives. And that's what you want to show them.
Yeah.
Thank you.
And you had to do a gala dinner for them. Of course. Show them this. Wow. Dr. Irene, what makes you have sleepless nights while planning to go and try to convince local investors to invest locally within the health system?
Thank you. That is a very, very good question. And I think why we don't have a private sector, most likely previously it happened. It appears like, when we talk about health, mostly looks like it's something to do with the public. I'm saying this because like when you talk about health, especially when you talk about social protection regarding health, we have 3 tiers. We have tier 1, which is non-contributory. This is financed by the government, and times you find the donor chipping into that. And then we have the second one when you have the contributory, where you are employed and you are employed in the public or private, but this is a mandatory when you have the National Health Insurance Funds. And then we have the third tier when we have the private or supplementary ones. So you'll find most of the private sector we'll find them in the private insurance companies, private finance arrangement. But now, initially, in some of the countries, we didn't have conducive environment for private sector to be engaged. Sometimes we'll find some of the partner state countries, their policies are unpredictable. And that makes it difficult for the private sector to go and make their investment. Remember, investment in health requires huge investment, requires long-term commitment. So once the private sector see the commitment, the political commitment, then that is where you'll find them coming in. Then the dialogue like this one shows the opportunity, because when we talk about health financing, it means there are a lot of things. We are talking on the supplier side, but we also have to talk about the demand side. And when we talk about demand side is the argument which was also brought out by Dr. Brian, that it's multi-sectoral. You know, even if you construct a road to a health center, then you are facilitating these people to access this facility. And when you say, yes, we have the hospitals, we have the doctors, we have medicines, but you have these people who cannot afford to, to come from home and go to the hospital, or these ones cannot afford 2 meals a day, then it means that they can not just take medicine without any meals. So it is a multi-sectoral approach. So for us, especially in East Africa and community, most of the partner states will find only we have the government, and the government there will find the donor community, but mostly you'll find the private sector sharing away on investment in health. And this is the right platform. And I think most of the partner states are going to learn from what best practices that we are going to get, from this dialogue. Thank you.
I appreciate all of you. I just got a message. Yeah, let's appreciate them, please. From a good friend in the private sector, it says, "Anangwe barikutubeshera." We are doing a lot, and we will discuss this after the break. I like that, because the dialogue has begun. The dialogue has started. So I want us to put our hands together for our speakers and presenters who have given us a good moment for us to have this open discussion. It doesn't end here. When you meet them in the corridors, when they're within this room for this period, please feel free to ask them any specific questions that you'd like to say. I must say, respect people with glasses. We pay a lot to see you. Let's give them a round of applause. Feel free. Feel free. Oh. We take a photo. Where the picture, guys, please, as we go for the break. Camera? Okay. All right, it's okay. I think they said they took when you were speaking. So let's appreciate them one more time. It's expensive to see. Thank you very much. So we're going to take a break. There might be a picture op, a photo op with the Honorable Minister and, of course, with other guests. But right now, we're going to take a very, very, very quick break. We are over time. And so maybe by 11:35, we can be back in the room. You can also feel free to walk in with your coffee or your snack so that we do not delay the starting of the next session. It's also equally very important because it's another panel discussion and the dialogue has just begun. So I want to leave you and love you at this particular point, and I'll see you after the health break. Stay well. Good luck. All right. I appreciate your kindness. I appreciate your cooperation. And I wanted to check, first of all, if all of us are okay. Are we intact? Everybody good? All well? All is well? Yeah, I just thought during the break, and I remembered I'm in the safest room ever. I should not have any worry. And I was even overhearing some people even doing consultation already for free. Hey, you guys take advantage. Hey. And someone was saying, hey, but there's a lot of sugar on this menu. Said, no, it's okay. Just one portion, only one. So the language out here is very amazing. I love this room. I love all of you. Thank you very much. So I want us to start this session. And because we are behind schedule, I want us to be able to delve right into it. So we're going to be having a panel discussion. And the title or topic on this will be Breaking the Financial Barriers. I love this. And it will go on to look at expanding health access through innovative health solutions. I think the underlying word here is innovative. The world is changing, a lot is changing. And so we cannot continue doing the same thing and in the same way and expect different results. So for this session, I would love to call the moderator for this session. And he's none other than Professor John Eleojo, and he's with the Canada Research, he is the Canada Research Chair in Health Economics at the University of Manitoba. Let's appreciate him as he comes, ladies and gentlemen. We can do better.
Ladies and gentlemen, it's a pleasure to be here and also to moderate this panel. It's going to be, in my own opinion, the best panel that you could ever attend. The reason is because we are trying to break barriers. And one of the leading problems that we have in terms of financing health services is around barriers to access. So how do we break these barriers to access? And we've got a menu here, a very rich menu of distinguished guests. I will call them onto the stage in a second. And you're going to hear more about how do we come up with innovative ways of financing health services. We've been hearing that buzzword for a long time. So let us bring it home in the context of Rwanda. So to kickstart, I will welcome, first of all, Mr. Regis Rujaman Sharu. I hope I'm getting it correctly. Rujaman Sharu. Please, you're welcome aboard. Mr. Rujaman Sharu is the Executive Chief Officer of the Rwanda Social Security Board. A round of applause for him, please. I'm still learning my Kinyarwanda, so we'll get there slowly but surely. Next, I want to invite Dr. Brian Chirombo. Dr. Brian Chirombo is currently the country representative of the World Health Organization, WHO. A round of applause for Dr. Chirombo. And I also want to welcome on board Stella Matutina Umuhoza. Stella Matutina Muhoza is a lecturer with the School of Public Health, University of Rwanda. A round of applause for her, please. I will also welcome Mr. Wandera Manasseh. Mr. Wandera is the Executive Director of the Society for Family Health. A round of applause for him, please. Lastly, but not least, I would invite Rose Kanyanje, who is a health financing specialist with UNFPA. A round of applause for Rose, please. You will notice our panel is well padded. We have the ladies pretty much guarding well the men. So we are undoing what used to be before. You know, previously men guard women, okay? But now it's the reverse, which is good news for us. So to kickstart, I want to thank you for joining us on this panel. And I'm going to ask you very tough questions because we really need to get to solutions. We've been talking a lot about problems, challenges. It's not going to end. We just need solutions, and that's why we're here. And I'm glad that the country is championing many, many things that would lead to better solutions. So I will, first of all, I'll start with Mr. I'll get it right now. Ruja Mansharo. You see, I'm getting closer.
Okay.
Shuro. Haha, you see, I'm getting closer. Rugeman Shuro. You know how critical Rwanda's health insurance is in improving access to quality health services in the context of Rwanda. Rwanda has many health insurance schemes that have collectively been able to insure more than 90% of its population. And it's enshrined in government policy that all Rwandans must be insured. We all know this. Yet there are few access barriers that exist that hinder people from being able to use health services in the country. We also know that premiums exist, especially for the scheme CBHI, for example, and these premiums are not well graduated by income levels. Currently, you have that most people pay about 3,000 Rwandan francs per family member to be CBHI members. Even though there is an upper cap of about 7,000 Rwandan francs, only very few people are in that category. So in the end, you figure out that pretty much everyone is paying the same amount of 3,000 Rwandan francs per person in the family. Now, what are the possible strategies for addressing the remaining financial barrier gaps in the context of Rwanda?
Thank you very much, and good morning, everyone. For the community health based insurance, and the other 5%, depending on the year, is for the public servant scheme that is also managed within RSSB. Appreciating the journey from where we were 7% in 2003 to where we are at 90% for the universal health care, for the remaining gap to be closed, which is the question. Some of the things that we've been discussing with my peers, both at within the government at Ministry of Health, Ministry of Finance, but also our other partners who work with us, is really to take up an approach of, how do we, it's almost like for those engineers in the room, it's like a system engineering optimization, right? How do we optimize the outcome? Limited resources to provide the most package to as many people without overburning those, increasing the burn for those who can't. Some of the strategy we're approaching is leveraging technology. As you know, Rwanda, our Ministry of ICT has done a great job, and private sector in really embedding technology within every service in Rwanda. So leveraging big data, understanding the dynamics within the communities, with the dynamic registry, for instance, with what's being done under the Ministry of Local Government, understanding who's covered, who's not covered, who paid 10%, who paid 25%, who paid 75%, and then figuring out, not from a aid perspective, but more from how do we create opportunities in actually allowing them now to afford the required contribution through services like VUP under the Ministry of Local Government. But on top of that also, as a government, we are thinking of new ways of increasing subsidies to support the scheme. For instance, for those who have been driving around, if you receive a ticket for driving fast or not wearing a seatbelt or being on your phone, 10% of it will come to cover to contribute to the insurance. And if you are visiting the gorillas or any other touristic place, you are contributing to the improvement of the healthcare package. If you are consuming alcohol, buying fuel, and so many others, and those things that gives part and a responsibility, or I'll say more of an opportunity to the citizens to contribute to improving our own system without the government always having to fund this from the budget. We can become very heavy. So, and when you take that approach where every stakeholder is involved is really focused on increasing the value proposition, it also means those who are not already in the scheme look at it as attractive. One thing we've been working very hard to change is the perception of the community-based health insurance. It's not a poor people scheme, right? It is a universal healthcare, but it's not for poor people. Meaning, as we continuously increase the package, for instance, last year we increased the number of products covered from 887 to 1,400. And this is going to continue as more means are available. So as the value proposition offered by the scheme continue to improve, it's more convincing. Actually, we're seeing people leaving the private schemes to join the universal healthcare. And we're seeing demands of saying, look, I'm using a private scheme, but if you ask me, you mentioned 7,000, it's true. It's actually less, it's low. Some people are willing, we're looking at segments willing to pay over 100,000 Rwanda francs, roughly close to $100, say, I would pay this much if I can use your scheme, meaning that the value proposition is increasing. We are doing more things and more access to services than we used to in the past. So it requires to be intentional, a lot of collaboration, because increasing the value proposition doesn't just mean you increase the package, it means the quality of service provided at health facilities is also improved, which the Ministry of Health done a great job at ensuring. You have to make sure that people are trained from a customer perspective, but also from performing those complex procedures they have to do. You have to make sure follow-up is done in time. The value proposition really, if you're not intentional, it becomes a slogan. But what if you want to convince someone, a convinced person doesn't have to be forced. They'll come willingly. And now they come with new ideas and new proposals. So I'll leave it at that. Happy to comment further, but it's really about continuously, intentionally, collectively improving the value proposition and giving the citizens an opportunity to contribute from different means of almost taxation. But that comes from what they do every day without overburdening them in putting a specific price they have to pay. But if I'm getting fuel, I'm getting fuel. If I'm overspeeding, I shouldn't. I'm supporting. So thank you.
Thank you very much, Mr. Rujamanshuro. I think that's a very good point to enter the discussion. So Stella, I'm going to come to you now. We've heard from Mr. Rujamanshuro in terms of the new ways of financing health services that came out through the Prime Minister order, okay? One of the latest Prime Minister orders, and that outlined some of the innovative financing mechanisms that he just highlighted, one being traffic fine and stuff like that. There are many of these initiatives that have been put in place to ensure that services are expanded to the population. And in doing that, there are still some gaps that still exist. He highlighted a few of them, but from your own experience working in the Rwandan health sector for many years, as the country continues to grow with GDP growth kind of projected over the years, we also know that that provides impetus for us to say we can expand services because we could now afford more services as a country. So keeping that in mind, in terms of expanding services, how would you ensure that when you expand these services, that process of expanding services will not in any way lead to significant co-payments that will overburden people and lead to a lot of financial distress? Because you currently know, for example, that people pay co-payments of about 10%. He mentioned that. Even ambulances, the cost of ambulances are not fully covered if you exceed a certain amount. So these are things that I want you to talk about. How do you expand services and you ensure that co-payments don't burden people? Thanks.
Thank you very much, Prof. John. Good morning, everyone. Stella Matutina Umuhoza from the School of Public Health. I'm a health economist. Thank you for a great question. I would say that as the life expectancy of the country improves, the country should be ready to provide most expensive services to cater for non-communicable diseases, which means that we should make sure that our system is ready to treat patients with non-communicable diseases, including cancer, diabetes, and so forth. But at the same time, as you improve the lives of expectancy, and you need also to have more spending in the health infrastructure, because treating NCDs requires investment in specialties, training more specialists, acquiring more expensive equipment, which means that if we are to expand the service package for any health insurance scheme, we need to mobilize resources and have a very transparent process for adding or removing the services to the package. I will not argue for removing the services because it's not politically correct. We need to find and make sure that we have a transparent and evidence-based approach of increasing the package, but at the same time keep in mind that of the available budget envelope. Based on the Rwanda experience of reviewing the benefit package for cancers, currently the School of Public Health is leading the process of reviewing the benefit package for cancers. And we found that most of the cancer services are very expensive. And as you move from cheaper drugs and to expensive drugs, you found that most expensive drugs are not cost-effective. So therefore, you have to be able to have a clear methodology and have capacity in place to make informed selection of drugs you can cover, and that the scheme can start to reimbursing to make sure that beneficiaries are financially protected. And on top of that, as you expand the package, you make sure that you get the buy-in, have the buy-in of all the stakeholders. You have the skills, you have the local skills, technical skills, and make sure that the scheme is become a strategic purchaser, be able to negotiate lower prices, make sure that you have cost containment strategies in place so that you can be able to negotiate lower prices using your purchasing power as the main scheme in the country. But at the same time, you have to institutionalize the process. Otherwise, when you don't have a clear process of adding or expanding the package, you are more likely to be inefficient. That's why we, as we advocate for expansion of the services, you have to make sure that the evidence and the statistics are the main ingredient we are using in the process. And finally, I would say that we are now asking the scheme to cover most expensive services, but at the same time, the patient has to still contribute, has to pay a certain proportion of the medical bill from their own pockets resources. And in that regard, I would say that we need to review existing co-payment policy, because a 10% of a $1,000 bill can lead to impoverishment, which means that we need to have, based on the best experience and practice from other countries, we need to start reflecting on strategies and processes of reviewing our co-payment policy in a way that we ensure affordability of the services, also ensure equity in access to needed healthcare services. Thank you very much.
Thank you very much, Stella. You raised a very important, or you said something that I kind of like. You said removing services is not politically correct. So what that means, thinking through, is that we need more services. So whatever we have now, we cannot renege on any of them. We need to progressively move forward. So I will quickly turn, in that regard, to SFH. So I'm going to call Mr. Wandera. You've heard what Stella said in terms of needing to provide more services than what we have. We cannot just stop where we are. We need to go further. And there is this current public-private partnership that exists in the country where, for example, even during, I think we heard from the HOD when he talked about initially having health posts being built by private organizations and then later on passed on to, rather built by and passed on to private organizations to help manage. Now, in that regard, what then are the challenges that we see in the country now to expand access to, especially health posts, keeping in mind the second-generation health post as opposed to the first-generation health post? What are the challenges that we need to deal with to expand access to health posts, especially in remote areas and rural areas?
Yeah, thank you so much. My name is Wandera Jehana Manasseh. I'm the Executive Director of Society for Family Health, a non-government organization that is working with the Ministry of Health, especially on the component of the public-private community partnership that the moderator is talking about. So asking about the challenges, of course, there are numerous challenges, but what I can say here is, and I will be able to list each of these challenges and probably focus on breaking these barriers, these challenges, and also kind of turn them, maybe call upon the private sector and other partners to see how we can turn these challenges into actually great opportunities for business, for profitable business, and also for health outcomes, good health outcomes. So number one is about the infrastructure. I think Dr. Muhammad earlier mentioned that in the last 5 years, the growth of health posts has moved from about close to 500 to over 1,200, kind of more than double. And this was enabled by people, the process of public-private partnership, partnering with different people to invest in the infrastructure and to improve those ones that were existing and non-functional. So that is one of the challenges. But this challenge actually can be turned into an opportunity because when these health posts were improved from 500 to 1,200, the number of clients or patients actually quadrupled. So you can imagine improving the infrastructure by doubling it, yet you move the number of patients from 800,000 to over 4 million people visiting in 5 years. So that means the demand is there. It is a challenge, but there's also an opportunity for the private sector to invest in this because the demand is very clear. And maybe for the people in the private sector who may fear us, we partnered with UNFPA and did a quick survey to see out of the so many health posts that are operating and we are working on in the framework of public-private partnership with the Ministry of Health, we tried to see if you supported them with training, with equipment, with the infrastructure, how profitable are they? We were actually positively surprised that over 70% were actually, they broke even after 6 months and became profitable. Even the 30% that we are remaining, it was because of different geographical factors that can actually be addressed. So that is the issue of infrastructure. Second one is about the equipment and the supplies. It was, of course, a challenge previously, but our partnership with the Rwanda Medical Supply, and I saw the CEO here, we had the conversation. We saw how we can do a partnership and reduce on the issues of transportation, billing, and it actually contributed towards profitability. So there are so many challenges: infrastructure, equipment, human resource, systems, technology, but all those can actually be turned around to be potential opportunities for profitability. So I can simply say that there are so many challenges, of course, but these challenges are really great potentials, and I call upon the private sector to come and join. Because you can see, if you can quadruple the demand, so you have money. So to me, I will give one more example about how we also use the technology, because we are having challenges of receiving that real-time data, and we partnered with Sun Technologies, which is a global tech company, to be able to digitize all these health posts that we are working on, to get real-time data at our offices, and we use this to make timely decisions. And we saw improvement in service delivery, in revenues, and in timely billing to RSSB, which came from 6 months to actually 1 month. And thanks to the leadership of the CEO here. So we are seeing these challenges actually turning into opportunities for business to deliver profitability, the economics part of it, but also the health outcomes. Thank you very much.
Thank you very much. That's well spoken, so you could hear that. I think the clap there is for the call for some private sector involvement. I guess that's where the clap is coming from.
There's money in the health sector. So welcome.
Bring it in. Thank you very much, Dr. Wandera, for that enlightening discussion, especially highlighting some of the challenges with regards to health post expansion. You mentioned again something that I like. I think it's good. You learn every day. He talked about public, private, and community partnership. So we've heard a lot about public-private partnership, but now he's adding a third dimension to it, which is community. So we have the public-private community partnership, and I think that lends us to something interesting in terms of looking for more innovative ways of financing health services. I'll quickly turn to Rose Kanyanje. You've heard a lot about a few constraints being raised there by Mr. Wandera, and we know that governments are challenged in terms of funding. There are opportunities that can be tapped elsewhere, whatever we define as elsewhere, and we need to begin to tap them. So how can we establish health posts, especially the second generation health posts, which we've been talking about? How can we establish them and finance them innovatively using domestic resources? I think I have to underline that word, using domestic resources as opposed to just resources coming from anywhere. The ones that we can predict, that we own. How can we do that? Thank you.
Thank you very much. Again, my name is Rose Kanyanje, just for purposes of pronunciation. And the health financing specialist from UNFPA. And I'm happy to be speaking on behalf of the UNFPA, talking of leveraging domestic resources. Our representative is here. So talking about sustainably financing health posts or innovatively financing health posts. I'll start by saying that the national guidelines for the operationalization and functionality of health posts are built on 3 main principles. One being geographical access, second being the quality of care, and third being sustainability. And it's also good to emphasize the fact that we are focusing on the third principle, which is sustainability. So what does it mean for a health post to be sustainable? It has to be in operation at all times, like working 24/7, at least for the second generation health posts, financially stable, and not compromising the quality of care. All that requires resources. So where does the money come from? The money comes from 3 sources. We mentioned it earlier: the government, the private sector, and of course, development partners. And we've seen the math around that. But speaking on domestic resources, how can we innovatively finance with domestic resources? One of the panelists earlier mentioned blended financing. And I would like to emphasize that going forward, we cannot run away or shy away from blended finance. We have to have a mix of the grants, but not just any grants, grants that are catalytic, that leverage more resources. For every dollar you invest, it should leverage another dollar. So it doesn't be the usual grant funding, but rather a financing mechanism that leverages or catalyzes more resources. talking about the private sector, there are a lot of opportunities around de-risking. If you are bringing the banks, for example, to invest further, I mean the local financial institutions, and maybe the bankers in the room can relate to this. There has to be a mechanism of de-risking or making it easy for the banks to find business in the health sector. Manasseh said there is money in health, so the banks should be looking around for where is the money or how can I lend more to the health sector. So de-risking financial institutions to help them make their life easier or be able to lend to the health sector and have a return on investment. So there are mechanisms like the credit guarantee that we are piloting through the joint program. UNFPA is leading this joint program in the spirit of delivering as one, UN reform. The joint program has many UN agencies, including WHO, UNICEF, UNCDF, UNHCR, UN Habitat, UNDP. All these are coming together to support these innovative mechanisms. So we are trying to pilot this innovative financing mechanism where we can provide de-risking facility to one of the local or more local banks to be able to lend to the health posts at affordable terms. With that, if you're able to support the financial institutions to do their business, but also contribute to the health outcomes, then I think it's a sustainable mechanism. And beyond the de-risking, once you have built the foundation of the banks being able to lend, even without the de-risking, I mean, you have built their health sector portfolio, they have gained the experience of working with these health posts, and in the long term, they might not need the de-risking facility. It will be normal business for them to actually lend and be sure that the health post operators will pay off their loans, will have a return on investments, and will deliver access or health care to the wider community. Again, talking about the private sector, what is the motivating or the incentivizing factor for the nurse entrepreneurs? I mean, if you open up a health post, it's not a free lunch. You also return some, you also expect some return on investments. So it has to be motivating, or you have to have reasons or grounds that you will deliver the health care that is needed, but also have some return on investment. So it goes back to how much you charge, or if I may use the tariff. We might also have to think of mechanisms of revising or regularly rethinking these tariffs. I think it was mentioned some time back that the current tariff is about, 7 years old, if I may put it that way. And if you look at the trends in the dollar rates, if you can flash back 7 years ago and you bring it forward to today, if you use the same rates 7 years ago and the same rates today, you literally will not be sustainably in business. So that's something to think about for the nurse entrepreneurs or for the private sector that is interested or would be incentivized to invest in this primary health care. How can we incentivize them? There's a lot to say, John, but I think I'll pause here. So thank you very much.
Thank you. There you go again. When you hear private sector, there's a lot of clapping happening there. So you know what that means. So we are making progress. We've heard a lot about whether it is building of health posts, financing innovatively, or looking at how do we ensure that there's financial protection in the system. What is very important is that the last person, the common person, by common I mean any individual in the country, we want that person to have access to healthcare that is of sufficient quality, and they, by so doing, are not faced with a very large sum that can be very catastrophic, for example. But to do this, we need to bail the cat. Now, the issue here is to be able to understand whether we've progressed, or we've retrogressed, or we are stagnant, or we just kind of ditched everything and we're going a different direction, which could happen. We need data. We need information. And information is is like gold for policymaking. Because without information, we cannot ascertain where we are, where we were, and where we are, where we were, and where we will be. So in that regard, I would want to bring in Dr. Chirombo. With the WHO and other development partners, they've been monitoring universal health coverage, looking at the two major dimensions, access to quality health services, as well as financial protection for all. And there's been a couple of reports put out there to tell us the status of financial protection or service coverage in different countries, including those in the African region. Now, even the Afro region on its own, which we all belong to, do the same in terms of monitoring financial protection for African countries. However, the data sets that are available for us to monitor financial protection are dated, they are old. Some of them, the latest you could have is maybe around 2015, which is the latest of the old. So you could have those that are as old as 2002, for example. Now, that is a challenge for us to be able to monitor progress going forward. As WHO, and maybe you think of other development partners that you partner with, what can be done at the country level, where we are now, to be able to close this information and data gaps such that we can timeously assess the country's status in terms of financial protection, in terms of access to quality health services. So I would turn the mic to you, Dr. Chirombo.
Thank you very much, Prof. My name is Dr. Brian Chirombo again. I'm the WHO representative to Rwanda. Thank you for this opportunity. I think I will start off by giving a bit of a framework so that we can talk about country and what we actually need to do, sort of global and regional, and then I'll come down to specifically answering your question. So, as we have already talked about, achieving universal health coverage is one of the 2030 SDG targets. And as we mentioned earlier on, primary health care is the best way of achieving universal health coverage. Now, as the chair has already said, universal health coverage aims to ensure that all people have access to the full range of quality health services. And I think we have heard from the previous speakers about how that's happening, especially in Rwanda, when they need it and where they need it. And this has to happen without experiencing financial hardship. So which is what I will try and address here. Financial hardship is linked to the use of health services in many countries. And part of the reason is because most of our systems have some out-of-pocket payments that happen. And some of these are different forms. And I think we already heard from Dr. Stella about the increased needs, about the increased cost. She has also mentioned, or somebody has mentioned, about access to drugs, particularly outpatient drugs. So these are some of the drivers of the financial hardship. So financial protection in health can only be achieved when there is no financial barrier to accessing care, and we don't have these out-of-pocket health spending that are actually required at the point of contact. Because usually that's what's happening. We already have paid health insurance, private, public, and when you get to the point of care, there are additional co-payments, and there are sometimes drug costs and other related costs. And that, unless we get rid of those out-of-pocket health-related spending, it's going to be very difficult to ensure financial protection. So the data that you talked about is very key, because for us then to be able to know where the country is, whether the communities and the households and individuals are protected from financial hardship due to the services that they access. We need to be able to track the financial hardships that are happening. At the global level, as you mentioned, the two main agencies that are working on this area on tracking is WHO and the World Bank. So every 2 years, we produce a global report. So we have a global report on universal health coverage, and then linked to that is some focus on financial hardship, because that's been a big challenge for us. And we use some indicators, SDG indicators 3.8. And there are two main indicators, which I think I've already had being mentioned, impoverishing health spending and catastrophic health spending. So we track those at the global level. So this is done every 2 years, but this data is not generated by WHO and the World Bank. This data is generated by countries based on surveys that they do. And one of the challenges we have, many of those surveys are done every 3 to 5 years. So even, for example, when you look at our latest report, most of the data is still from 2001 and before. And Chair, you have talked about some of the challenges that we have with data in our region. But however, it's important to see or look at what's been happening in terms of access to data. Before COVID, globally, most countries had data available, including many African countries. But post-COVID, we do have a major challenge. So of course, it's not just COVID. There are many other factors. So it doesn't mean all the countries in the region don't have data. So for example, I can mention a number of countries in Africa which have some data from 2018. You know, Cote d'Ivoire is one, Angola, Burkina Faso, CAR, Chad. So there are some countries that are beginning to make sure that they generate this data. And this is particularly helping. And this is critical, for example, with the COVID pandemic. And we haven't really fully recovered from the pandemic. Of course, we're not out of it. Yes, we are not in a public health emergency, but we're not out of it. So, but I want to also note that it's not only in our region where we have all data. So when you look at the data that's available, for example, Denmark is still using data from 2010. Finland is using data from 2016. Switzerland is using data from 2017. So I think it's important to have that context. Yes, we have challenges, we have issues, but the issue of data is global. It's a challenge. When we come to our region, some of the reasons why we have more challenges with getting this data particularly relates to these. To generate that data, you need population-based surveys. These are quite expensive. And many of the countries struggle to be able to mobilize enough resources to do them regularly enough, because you have to do them regularly enough to be able to track. If you're going to track, you can't do like we have countries that last did, I saw even a country which last did in 1998. So it's very difficult to then be able to track what's happening in terms of financial hardship. So it is key, but the challenge is the resourcing. But of course, COVID-19 disturbed a lot of things. It was very difficult to do surveys during COVID-19 pandemic. But even where some countries are able to collect this data, in our region, we also have a lot of capacity constraints, because the indicators that are generated for financial risk protection are not routinely calculated. So many countries struggle with being able to generate the data. So I'll just mention a few points. So I'll talk about Rwanda, but this is general. I think the first point is we know that it's expensive to do this service. So what is most reasonable and what we suggest as WHO is countries to use existing surveys that are already established and add to them the data or the data requirements for being able to track financial risk. So when we come to Rwanda, we have the Integrated Household Living Conditions Survey, which is done every 3 to 5 years. So our recommendation, just like we do with other countries, is for that survey, so it does look at socioeconomic information and changes in how households are living and their conditions. So we think that it should be possible to revise some of the questions, include some questions that can help to track financial risk. And us as WHO, we are actually available to work
with the National Institute of Statistics and partners to do this. Because the advantage of that is this survey is already being done. So you are not starting from scratch. You are not mobilizing additional. Of course, you need to add some resources, but it is much more efficient to add a few questions. And when you do the report, you are not doing, currently what we're doing is we're doing a lot of ad hoc analysis of data. So you do it as part of analyzing the EICV, for example, for Rwanda. So that will be much more efficient. You will then be able to get this data more regularly. Then the second point is Rwanda does have the health resource tracking tool. And that's another opportunity that could be used to ensure, of course, we know that the data will need to be more comprehensive. It needs to be more disaggregated for us to be able to use it to track financial risk. But this is an opportunity that could also be used. And then, of course, as WHO, we are available because you need, again, to bring in all the different sectors and partners to discuss, to look at other sources of data, because, yes, these are the main sources of data, but it's possible to look at other ways of generating this data. So this is something maybe that needs to be done, where we need a dialogue, and WHO is available to co-facilitate that dialogue that would involve all the critical stakeholders, Ministry of Health, Ministry of Finance, local government, National Institute of Statistics. So we think that these are some of the things that could be done to make sure that we generate data. Of course, when we have enough resources, we can conduct these surveys. But what WHO has seen is that it is quite challenging, and it's really better to utilize existing opportunities and just add small pieces that then allow you to monitor and track financial risk. Thank you.
Thank you very much for that interesting angle, which I'll talk about now, Dr. Chirombo. The aspect of the current revitalization of the HRTT, I think offers us a unique opportunity to figure out how to make sure this is an automated system that allows us to track progress. Although there are challenges with the health resources tracking tool, though there are challenges with it, but we can build on that, like you said, to ensure that we can routinely assess financial protection. And I like the bit about adding on a few, tweaking here and there, a few questions to ensure that routinely collected data are usable, readily usable for researchers and even within the Ministry of Health to routinely monitor progress on the front of financial protection. Now, we don't want to just end with the panelists because we are here as a dialogue. So we have started the dialogue. We're now moving it to the floor. I would like to talk about the issue of community property. Community property belongs to no one, okay, unless you begin to give it a name. Who owns it? Think about a sheep that lives in your community. Everyone thinks they own the sheep. The sheep will move from point A. Oh, well, B has fed this sheep. Moves to point C. Oh, yeah, A has fed this sheep. And this sheep keeps going round and round and round and round from A, B, C, D, E to Z. Hungry, dies because no one feeds it, thinking that the other person has fed the sheep. So now we want to ensure that we kind of give name to the challenges we have and then find solutions. And in finding solutions, we now need to know who would take these solutions forward. Else the solutions will just be lying here and we just go home where we knew what the solutions are. So I want to call upon you, when you reflect on the challenges and also preferring solutions, you can indicate by raise of hands. If you indicate, I would select. Maybe I only have time for maybe one or two persons, so be quick about it if you want to make a cut. So when you talk about the solutions, please also try and profile who you think can lead it. We want to take action. Who leads that, if you can? Yes, I can see. I need women. So I'll go with Cashew there. I'm sorry, I would go with a woman this time. Let me go, the one in green there. Sorry, I can't get the name. Thanks. So let's take two questions from them. Let's start with a woman first. I like that. Then we come to, yes.
Thank you very much. My name is Vestina Muchachimana. I'm the country director for Water Aid in Rwanda. I first need to appreciate the very good conversation and the existing holistic consideration for health financing. Mine is just, I will base on the say that for the team to be a champion, all pieces of the puzzle needed to fall in the right place. And my piece of puzzle now is water, sanitation, and hygiene, which is our focus. And we believe health cannot be called health when water, sanitation, and hygiene is not there. This has been very long time considered for prevention of diseases, especially those that are communicable. But as the pattern of diseases is actually increasing from the other side of non-communicable diseases, I think it is time to also recognize these three elements as very actually more important for non-communicable diseases and patients to be able to endure and cut the costs as we increase the quality of health care. So I need to check with WHO representative, where do you think this piece of puzzle is in terms of maximizing the cost effectiveness of health finances that are there and maximize the use for proper outcome in terms of health populations. Thank you so much.
Thank you. I will take the second question before we, so at least we know who that question is directed at. Yes, please. No. You. Yes. Sorry. He was the first person who even raised hand. So.
Thank you so much, Professor John. My name is Dr. Yeko. I'm the Senior Health System Strengthening person at Clinton Health Access Initiative, CHAI. My question goes to strategic purchasing bit. Quality of service is what needs to be purchased by any of the insurance schemes. And service quality is ensured under policy by Ministry of Health and Rwanda Biomedical Center for the service provision arm in the ministry. So how do we make sure that gaps in quality of service and the voice of clients of our either community-based health insurance or other insurance are being heard, incorporated in the service package that we are purchasing? We have a clear provider and payer differentiation, which is RSSB and then the service provider. So how do we make sure that the contractual agreement enforces if quality is not ensured, payment will not be made, or other providers such as private sector providers are chosen because of their quality than public provider? Thank you.
Great. So I would want to quickly ask for responses there. Maybe you want to start, Dr. Chirombo, with regards to WASH and how WHO kind of fits into that. Thanks.
So I think let me start by saying that, we have the next COP that we are preparing for. Mm-hmm. It's very good now to see that there has been agreement to ensure that the whole issue of climate, environment, and health is pushed to the forefront. Actually, now we are working with ministers of health to make sure that they're at the table, to make sure they are talking to the ministers of environment, and ensure that climate, environment, and health is included in the whole thinking about how we address climate and the environment. Because up to now, there's been a big gap there. So water and sanitation is obviously one of the key pieces in there. We know that the environment is, first of all, a lot of diseases are related to the environment. So a lot of the risk factors come from the water, the sanitation, etc. So it's key to make sure that water and sanitation is integrated. It's part of the whole response. Of course, water and sanitation is not about health. So actually, most of it is outside health. For example, Ministry of Infrastructure is the one in Rwanda who leads that. But there are other ministries that need to be engaged. Other sectors we have to be involved. So at the moment, we are already working with other partners in addressing water and sanitation. We're working with UNICEF, we're working with other agencies to support government to address water and sanitation. So it's really important that it's included as we talk about financing. It needs to include financing of water and sanitation. Of course, for us, because we are in the health sector, we put a lot of emphasis on our health facilities because we don't want people to come to the health facility and you don't have safe water, you don't have safe sanitation, and then you actually come out with infections from there. And so we are already working with government, trying to ensure that all the facilities have safe, because for us it's not just about a point of access, that there's water. But we want to make sure that all the facilities, all the sectors, maternity, does it have water access in every point so that they have safe water? Are we taking care of the sanitation? So for us, that's been our focus. But of course, we have all the other partners that we work with, UNICEF and others, who also address other components. So the key thing is it's part of the response. And what we're hoping is as we get more focus now on ensuring climate and environment and health are pushed to the forefront, water and sanitation is one of the areas that we'll be working on. And as I said, that has to be done, it's multi-sectoral. It can't be health. Most of it is actually outside of health. Health has a critical role, but we need to work with other sectors. Finance needs to make sure that this is adequately financed. Other ministries, environment, needs to do their part to make sure that we actually have more safe water and safe sanitation. Thank you.
Great point there. He talks a lot about the social determinants of health, that it's not just about the health sector, but every other sector should work collaboratively. I'll turn the last question to Mr. Rugemansharo. I hope I'm getting it right. Rugemansharo. I got it right. Shuro. Okay, see, I want to give you A. I think I want to promote you from U to A. So yeah, you should be happy about that. Rugemansharo. Now, the question is about strategic purchasing that was raised by Jacob. How do you then, he talks about bringing in voices of clients and service users. What's your take around that?
Thank you, Jacob. A very good question. Earlier in my intro, I mentioned about a collaborative effort by all the stakeholders involved, but also leveraging data and everything towards a member. We call them members, patients. They are members because contribution are members. Everything has to be centered around them. So that value proposition that continue to increase over time, and all the pieces now need to be shaped to make sure that there's efficiency at all level, whether it be from invoicing, whether it be from a purchasing perspective, whether it be from quality of service, whether it be providing training, whether it be providing financing for equipments, which is also part of what we do. All that has to be intentional. It happens that RSSB's strategic plan for the 2020-2025 is centered around its three words. I'll summarize it: member first, data-driven, and high performance. Member first in the sense that everything we do and everyone we work with is towards our member and ensuring that they're getting the most premium service, the resource available at our disposals, and the partnership we have as an institution go towards improving or delivering that optimal service that is we can afford. Strategic purchasing and monitoring quality of service are very centric to that process. And I think, Chai is actually a good partner of ours for many things we do, whether it be reducing the timelines of invoicing, digitalization that is happening, that has reduced from 6 months to 35 days today, and aiming at 15 when the digitalization is complete. But leveraging data, and I know also a lot of work we do is understanding what pays for what. right? How much are we spending on cancer treatment? How much are we paying for specific diseases? And in the end, you want to figure out, is this costing us too much? Is there a better way to get this maybe in the bulk? Or is it a way to have a partnership that gets this straight from the source? Right now, we have a partnership with Pfizer through the Ministry of Health for some of the cancer medicine that was not available, but is now available and availed to CBHI members. In regards to quality of service, again, it comes back to that value proposition again. It's one thing to get treatment, but it's how you get it too, right? And that Ministry of Health has a particular monitoring program with PBF and assuring that, and as we do also, it's like an audit way where we make sure that, yes, you are treating people, but are you doing it faster? Is it clean? Is the conversation okay? It's not just like robotics, in and out type of processing, right? Which is when someone comes to see you is already sick. So it is something that we prioritize because in the end, you're dealing with humans. And not only you have to manage the cost and efficiency in end-to-end of what you do, but also to the emotion that goes with it. And we appreciate all our partners who really walk the talk with us, starting with Ministry of Health, Ministry of Finance, CHAI, and all the others that we work with. All the results you see, and when we talk about numbers, sometimes they make us look good, but it's really, credit goes to all our partners who come and understand, help us dissect the problems and get into the numbers and actually commit to delivering, whether it's bringing experts who actually go and break down the numbers in ways we can do, but also assuring that we are monitoring efficient implementation in a way that is quantifiable. One small remark I want to make about how do we also address, one thing I think I've personally appreciated in the process is when we talk about those who are not insured and how do we bring them on board. One thing I've appreciated to see the effort from the Ministry of Local Government and Ministry of Labor, and we have what we call a dynamic social registry that has been created, and this traces your level of income over time, and the amount of effort that is invested in identifying who has what, and who's actually doing better and or less, and not providing just ways to help them, to give them aid, but how do we give you training? Are you a farmer? Are you part of a cooperative? Are you part of, what can you do that will allow you to earn an income? And I think, our colleague, you mentioned something about sustainability on that side, on delivery of service, but sustainability on affordability of service, which means, and I think it's really what's going to make this process sustainable is, how do we identify these people, ensure that there's a value proposition that is convincing, but also ensuring that they are trained to afford the service that is provided. Because they can, while they want to, instead of giving them money, what is really sustainable is say, okay, you're a farmer, this is how you use input, this is how you use fertilizers, you are part of a cooperative, this is what they do, what can you do? And we've seen that last year, government dropped about more than 50% of the people they used to pay for. And over 50% of those dropped ended up paying for themselves, right? Which it's a graduation system. And this is really what I think is going to show that we don't fall back. Like, you have to graduate, but you also have to support people. Don't give me a fish, teach me how to fish, and then I'll do the rest, feed myself. Thank you very much.
Thank you very much. I think they all need a round of applause. What I can quickly summarize in a few just less than a minute. What I have learned from here is that we need more money, and the role of the private sector is heavily highlighted, and government's leadership in that regard is equally key. We also need value from the money in terms of efficiency. Not just that we need more money, but the little we have, how far can it go? We need to be efficient. We've heard that across different dimensions. And also we know that in doing so, services have to be available, especially at the lowest level. We've heard a lot about a large chunk of users should be concentrated at lowest level in terms of health posts. If you can treat majority of cases there, then you have fewer cases that are moved up higher the hierarchy. And lastly, we need to assess progress. We need to know where we are and where we are and where we'll be, and we need data. And access to data is very critical, and we hear that coming out clearly. So to close off, I want just a final word. Now I have $100,000, okay? I wish I'm rich. Now I have $100,000, and I'm giving the health sector. And I want you, just your final word, what service do you think that money should be spent on? So I want to start with Rose. If you're given $100,000 now and you work in the health sector, what service do you think we should spend that $100,000 on? Yes, think about it. I give you an example. It can be human resource. It doesn't necessarily mean the disease. But what should that money be spent on?
Thank you. Like I earlier said, I would use that money to catalyze more. So if you give me $100,000, I should be in position to make more than $200 with it.
Good. She will invest. Good.
Yeah, thank you so much. So if you gave me $100,000 and you ask me how should I spend it, I would give you a triangle, an inverted triangle on infrastructure, equipment, human resources, technology, and research. Then I...
Choose one.
Yes. So with this $100,000, I will spend it on technology. Then technology would be a game changer to affect the whole part of the inverted triangle that I was talking about.
Technology, digitalization of services,
yes.
and records and stuff like that.
Yes.
Brilliant.
For me, I wouldn't give you one specific service. But for me, we need to first of all look at where we are with regards to the primary healthcare system and identify areas that we should invest, because it's only primary healthcare. It's the best way of getting us to invest our health coverage. And it ensures that those services are closest to people. Of course, by the way, primary healthcare is not peripheral service. It focuses on the periphery, but it still needs to support the whole system. So it's a systemic approach, but it ensures that the services are available. So I would put that money into strengthening the primary healthcare system.
Great. So he's talking about strengthening primary healthcare system or services as opposed to centers. It's because it cuts across all the levels of provision. Great. And you? What do you have to add?
Thank you. They've covered some of what I had in mind, but I think one of the things we really want to do well and more is increasing the package we give to our members. There are some services that are limited to other schemes that our members don't have. Thank God, and to everyone involved, some of them like heart surgery and transplant, kidney transplant is starting to be done here. But I would invest in capacity building, training more doctors.
Capacity building. Great.
Do things we can do today.
Yeah.
Good. And you?
Yeah, for me, I will invest in the prevention because more institutions are very keen to provide health care. But as we invest in the prevention, we are more likely to improve the life expectancy. We are more likely to reduce the burden of disease and also reduce the cost of health care. So I know investing in the prevention requires a huge amount of investment, but the return it will be very high. Thank you very much.
Great. Thank you so much. Now, the reason why I asked the question is basically we want to increase domestic resources. If you don't know what you want to use the resources for, we shouldn't be going out in the first place to even look for more resources. And we are getting here that they have an idea or have ideas around where to put the money. So I would want to welcome you to please give a round of applause to our distinguished panelists. Thank you so much for coming. So you may take your leave. Thank you. And I will hand the mic to my able Eugene. I like the way you call your surname. You kind of relax when you call it. I want to be like you when I grow up.
Thank you, Prof. Thank you. I'm actually looking for a successor. Whoever in the room can say it that way, I retire. I retire. Thank you very much. There's a good question you asked. But you spoiled it when you said you don't have the money. I was about to answer that question. If you had asked me what I would do with that money, the $100,000, you'd have just let it at that. You wouldn't have said you don't have it. But I know there are people in this room who have that money. At least you've heard where you can be able to put it, especially those within the private sector. You have an idea of where you'll put that money. I want us to rush real quick. There's one thing that even doctors have recommended. It's very dangerous to stand in between people and their lunch. Very dangerous. Doctors recommend that. And so I want us to really be very quick on this one. We have just one panel, and it will cause us to have at least around 30 minutes delay for our lunch break. So I want to call upon the moderator for this session, and that is none other than Mr. Paolo Reggio, who's the advisor to the Ministry of Health, to the Minister of the Ministry of Health, and he will then be able to call upon the panelists for this session. They'll be talking about sustainable health, workforce production, and retention. It's a good one. Let's appreciate him, please, ladies and gentlemen.
Good afternoon, everybody. Miriwe. And I think we have a challenge here because the session before lunch is always quite complicated. I hope we can stay together and get through it. And as we say here in Rwanda, turi kumwe. So it's a real honor for me to introduce this session, and that will basically address one of the issue that is really on my heart, and really like about development and preservation of a healthy workforce. And really link it how domestic financing can really has a crucial role on that. The previous panel has asked, how should we invest the money? And I think this panel will explore more, how we think that prioritizing human resources is a critical element to reach the objective of universal health coverage. So without further ado, I would like to introduce my panelist, Dr. Menelas Nkeshimana. He's the head of Department of the Health Workforce Development at the Ministry of Health. Please, a round of applause for him. So we have also the Professor Abraham Amitike, that is the principal at the College of Medicine and Health Science at the University of Rwanda. Round of applause. Dr. Fulgence Nkikabahizi, Vice President of the Rwanda Medical Association and also Director General of the Nyabikeng Hospital. Welcome. Welcome. And finally, Dr. Achenga Ling, Program Manager, Health Workforce at the Clinton Health Access Initiative. So I think we have a very, I'm so honored to have such a very panel with different background from the government, from university, from like medical association and from practitioners, and also from development partners. So I would like to start some way from to understand a bit the landscape from the Dr. Menelas, to understand what are the current challenge and policy change to really to build a sustainable health workforce here in Rwanda.
Thank you very much. First of all, we all agree here that we need to invest in the healthcare workforce, especially in this post-COVID era. We have learned a lot of lessons that put us at the same level of conversation for this outcome. The population, the density of the health workforce in Rwanda, as you have seen it, is at a critical low, whereby we count one healthcare worker per 1,000 population, while the minimum target should have been 4. And we did self-assessment on this and realized that if we kept business as usual, it was going to cost us 185 years to catch up to the 4.5 target set by WHO. And we did have reason documented for this. One would be access to education. What do we know about the access to the training? Is it affordable? The trainees are there, but are they able to afford the education that we want them to pursue? Do we have the skilled trainers in the country? And we had a pipeline analysis a couple of years ago that showed that the training capacity in our teaching institution is not maximized. Roughly, I can say, for example, for the nursing schools, if you put all the country capacity together, they are only able to enroll at roughly 50%. For certain areas like midwifery, if we waited longer, in years to come, we'll be asking ourselves, how did a midwife look like? Because they are enrolling at 20%. And of course, we have gap in the faculties as well. And for the basic science specifically, it was at critical low in terms of availability of faculty. How do students perceive education? Of course, as you see, it's not unique for Rwanda. People go to health education targeting the high-paying specialization. That's how areas like midwifery, nursing, biomedical engineering have been having a lower enrollment rate. The distribution of the health workforce, again, this is not unique for Rwanda. We also see it in Rwanda. Everyone wants to be in the big cities. And you always wonder who is going to be in the rural areas, because we need to develop these areas as well. The retention and attrition rate, these are some of the causes that I can mention. Looking at the nurses, we had data that showed that for the newly appointed nurses, in the first years, 3% will drop out. Of course, that's going to be cumulative. In the end, where you put people, they are not going to stay there for years that you want them to stay there. They're motivated, and the incentives issues are yet to be harmonized. And to top that, the health workforce migration. This has reached legal and political dimension, be it inside the country, on the continent, and beyond. They are in constant movement, and we seem to have no right formula for that globally. So what can we do in terms of policy change? For example, in Rwanda, we have what we call the 4x4 reform. It's one major reform that is being implemented, which means we have to quadruple the current health workforce in the next 4 years. Of course, for trainings that require longer time for training, we expect the outcome much longer than that. But at least the start should be now. And what do we do technically? It's increasing and maximizing in the enrollment rates in our training capacity as of today, starting from the priority areas. We can name them area of anesthesia, be it anesthesiologists or non-physician anesthetists. It's at a critical role. We make sure that we support it with all we have and together. We have to establish, of course, additional program to plug the gap. We know what takes people outside of this country. They go usually for cancer care, renal transplantation. We make sure that we have programs that are going to take care of that. The expansion of the training capacity is needed as well, because as you create a new program, you have some work to do with the renovation and redesign of the classroom. And I want to take this moment also to thank everyone that is involved in the provision of scholarship, because this is one thing that made students not going into schools. So we have been working with UNFPA, USAID, and others that are going to be joining. Scholarship is something that has to be supported to have the goals that you need to achieve. At a higher level, of course, we have other reforms. The reform that touch in the primary healthcare, where we have a new layer of community health workers that is going to allow us to have a deeper and a stronger penetration in the community, from 85% currently to 95%. These are going to be around 9,000 with new tools. They have to pass through education. They have a curriculum designed for them, which is context specific, and they are going to be deployed also to reach to the desired targets as a country. Of course, we are not going to leave behind the welfare reform that we owe the health workforce at the moment.
Very good. Actually, thank you very much for these thoughtful insights. And I really I was very interested to say it might take us 185 years if you keep on the current production level maybe in, I don't know, 6th generation, our grandchildren will be able to see Rwanda with an adequate level of healthcare professionals. So that's very interesting. And also, I mean, that's very interesting. You talk about production, increase, quadruple the production, quadruple the density of healthcare workers. That's something that's very an aspirational target. And I would like really to understand on this, the perspective of the university. So for the government, we have quadruple the production, but maybe I can, it's a pertinent question for Professor Abraham to understand how do university can balance this kind of like this objective of producing healthcare professional with the objective also of ensuring quality of trainings.
Thank you very much. This is a very tricky question, the balance between quantity and quality, which I was being challenged throughout my academic professional life. Ideally, to balance the two, or the trade-offs, initial investment is required in terms of educational infrastructure, human power, lab facilities, and also clinical facilities for clinical rotation should be developed ahead of time so that the balance is maintained. However, there is already a prevalent gap in health workforce. Not only in Rwanda, this is global challenge. So if we wait until we have everything what I have mentioned, it will take us again to tomorrow, and the gap will exponentially increase. And like Dr. Minelas said earlier, even with the prevalent gap, it will take us, if we go the way we go, it will take us close to 200 years. So we are saying our generation continue suffering. So what is the best is to maximize utilization of the available resources and also add some innovations on that so that somehow we can increase the number without compromising the quality of educations, like utilization of laboratories. We are using probably one afternoon or one morning. Why don't we use them both in the morning and in the afternoon? Why don't we use them in the evenings, weekends? The same is true for skill laboratories and libraries. Our library in University of Rwanda, it works only working hours. During the working hours, our students are already in classroom. For self-directed learning, they need it to function off working hours. That is not happening. So we have to change those issues. And thirdly, technology. In the previous, I use it for technology. I do share that one. That will be the future of education. Thanks to COVID, there were several innovations, and utilization was somehow harnessed during that period. Now we are setting back. So we have to utilize those platforms, digital platforms, that can help or that can facilitate education. There are both for classroom-based education as well as for practical education. So that's the other thing. In parallel, taking the existing educational facility gap into consideration, and also anticipating the future developments and gaps, capital investment must be done. And that investment has to be well thought. If I take you through what University of Rwanda College of Medicine and Health Sciences did in line with the 4x4 strategy, when this appeal comes from the Ministry of Health of Rwanda, we didn't plan for it, but we sat down and assessed what we have in terms of human resource, what we have in terms of lab facility, classroom, and so on. So we responded that we can double our intake in selected programs like medicine, pharmacy, clinical psychology, nursing, midwifery, and so on. So we doubled our intake in response to that. We didn't quadruple, but in the coming 4 years, the resultant will be that way. So when we double that, our intake, again, quality will become an issue. To take care of that issue somehow, what we did was we cascaded the intake. The first intake of those students started their education in June, and the second intake are starting next week, so that the first intake already has finished a semester of education, and the second intake are to start, so there is no overlapping. Somehow we have avoided the risk of quality compromisation. And at the same time, we are preparing for capital investment with government, Ministry of Health, as well as other sector organizations and partners. We are working to expand the College of Medicine and Health Sciences, not only for the current gap, but also for somehow our future generation, somehow for about to the level that we understand. So that's what we are doing for College of Medicine and Health Sciences. Thank you very much.
Thank you very much, Professor. And I think I really appreciate this, working on efficiency, like value for money, increase capital, so money for health. We are touching all the objective here, and it's very aspirational what we have mentioned. I would like to shift a bit on the other aspect of, we have talked about production, but the other aspect is also retention. Not only producing, but also retaining healthcare staff is actually a critical strategy. So I would like actually to pose a question to Dr. Fulgence. I would like to understand about, from the perspective of the medical association and also from your experience as a Director General of a district hospital, what are the insight about the status of healthcare workforce retention, and which strategy or solution can be implemented to address this issue?
Thank you, Paolo. First of all, allow me to thank our partners and the Ministry of Health that has supported our recent activities worldwide. The Rwanda Medical Association has hosted World Medical Association General Assembly last month at Kigali Convention Center. We appreciate all partners that have brought their support because the event was very successful. The Rwanda Medical Association is an organization that is an umbrella of different medical society, and it gathers all medical practitioners. We work with various partners, and primarily the Ministry of Health. Recently, we have been engaged by the ministry to assess the retention and motivation of staff. We found some issues or challenges that are bringing not only medical doctors, but also other healthcare professionals to move from their working place to other places. Mainly, the movement is likely to from the rural area to the cities, mainly Kigali, but also other satellite cities like Musanze, Muhanga, and other developed cities. Those challenges, I can list them and comment a bit. We observed low salaries, particularly in the public sector. When we compare salary of, for example, a nurse or a medical doctor working in a public health facility and the salary of the same category of staff working in private, there is a huge difference that can range from 40 up to 50%. These always bring health professionals to move from public to private, looking for better salaries. And private apart health posts, but private health facilities are located in cities. And this bring a kind of inequity in terms of distribution of human resources, and it can affect quality of care. Another challenge was absence of monetary incentives. One of panelists came to talk about PBF. It's performance-based financing. It's a kind of incentive that is supposed to be provided to the health care providers, but most of health facilities, particularly those who are in a rural area, whose incomes are low, cannot afford to compensate all staff that benefit. And this also creates a kind of other exode from rural to the urban areas. Another challenge was limited facilities, social assistance, like schools or other social needs for health workers, particularly in the rural area. Lastly, that movement created a kind of relative increased workload by staff. A health facility with a high turnover, the remaining few staff try to cover all services, and they are overworked, and the environment may not be favorable for staying in that health facility. As part of solutions, because as Rwanda Medical Association, we don't look at the problem and stay quiet. We engage with our authorities and our community, and that is a big mission of our association, is to interact and suggest possible solution to solve problems we are facing. So, as Dr. Menel has come to say, that strategy of 4x4 strategies, I strongly believe it can, with time, it can solve the problem of retention. Because if the health workers are increased in quantity and in quality, their skills are enough to provide quality health of care, both staff are motivated to stay, to provide, but also the workload may decrease because we will have enough human resources to cover needed services. Another suggestion, which is, I know, under pipeline, is reform of salaries. There is a proposal in pipeline that we wait its publication and its implementation that may increase salaries of public health sector. I'm sorry to insist on public. Probably I have been working and I'm working for public health facility, but I don't forget private, which is another also area to talk about. In a public health facility, the government, if may implement as soon as possible that proposal, it may bring a sustainable retention. But we suggest that there should be a differentiated package. For example, a staff working in a very remote area, which has a burden of traveling, cost of travels, and stay in that area, and has less opportunities to accede to a second employment, for example. That staff may be allowed a substantial package that may lead him or her to stay in that area. Indeed, that reform may lead to a reverse movement we are observing currently, and this should really be a good solution. The last is a kind of non-monetary incentives. For example, in the health sector, we have what we call Muganga Sako. We know that there is other possibility with commercial banks that can help health workers to afford some of their needs. For example, houses or vehicles or other. We are thinking of increasing economic capacity of health workers in a way they can probably not rely on their salaries also. They can create some microeconomic project in their area they are working. So that means a non-direct monetary incentives, but at the end it is monetary because the staff may benefit from his contribution also. So in brief, our research as the Rwanda Medical Association contribute to other stakeholders' discussions and suggestions, but we believe this will need that the government invest and commit financially a big commitment, financial commitment to the health facilities and to the health system. I thank you.
Thank you very much, Dr. Fulgence. I think that's very thoughtful comment about, making the case how the government shall invest, especially to fill in this gap. You mentioned the gap between rural and cities, and the gap between salaries in the public and the private sector. You mentioned up to 50% more in the private sector. So this is a real issue, and you're making the case for a broader reforms of salaries that I think it may well fit the reform of 4x4. They can work together to really address the problem systematically and according to the overall system, and to making sure that the resources that are produced with the 4x4, they are retained, and we can really have a functional and a sustainable workforce. We can have some way. It will be interesting also to understand the perspective of development partners, and we have here Dr. Acheng. That my question is, from a development partner's perspective, what are the specific challenges and opportunities when investing in healthcare workforce sustainability in Rwanda?
So when you speak of challenges, I think my colleagues have covered that very well. So I'm going to mention a bit on what are the opportunities. So one thing that I'll say is we definitely need to strengthen data-driven planning. So workforce needs forecasting. We need to utilize advanced data analytics so that we can project future healthcare workforce needs by analyzing what are the demographic trends, what is the disease prevalence, and the evolution of healthcare delivery systems. So this enables us to plan precisely the number and the type of professionals needed by the country, and also when to timely deploy them, where to deploy them, as well as looking at what are the infrastructural needs, how do we need to expand, what are the equipment needs, so that we optimize the service availability and avoid underutilization. This same data analytics can really help us when we're looking at retention strategies by enhancing the examination of data. We can understand, are these incentives that my colleague mentioned previously, are they actually working? As we are trying to incentivize doctors in rural areas, we need to evaluate when we are doing professional development, when we're increasing salaries, are they actually having the impact that we hope for? Is it bringing about change? So this analysis is particularly relevant to primary healthcare because community health workers, we need consistent staffing And it's also crucial when we look at how we train them and the quality that they produce and the accessibility to the population. I'll also mention looking at fiscal innovations. I think a colleague of mine in the previous panel mentioned this. We already have the health insurance levy within the country for domestic financing, but we also can look at other innovative methods such as social impact bonds, and how can we as development partners appropriately inform government on how to leverage the data that they have to get some of these fiscal innovations in place. So looking at, can we get upfront capital for programs that look at outcome measures as incentive for more investing, especially from the private space that usually can have allowances for corporate private investment in government priorities. So as we continue with health workforce being one of the foundational pillars in the health system, we know that it's characterized by high recurring expenditures, but we really need to help with the partnership with government to continue these financial commitments. Additionally, for ourselves as partners, looking at where do we have efficiency gains and how can we invest. Most of our programs are limited by our funding cycles, and health workforce is a long impact or long game investment. So how can we look at internally advocating for more funding to go to pre-service training to support that, as well as looking at how our programs leave behind an impact in health system strengthening. Thank you.
Very good. Thank you very much. I really, so we are talking about, evidence of data, how we can use data to assess and evaluate this project, how we talk about innovative financing, how we can have a targeted intervention. And I think, we have put together a lot of different perspectives here. We are talking about, production, we are talking about retention, we are talking about how can be the contribution of partners. Now, for the sake of time, I will be maybe calling 2-3 questions. Please raise your hands. I see hands there. So we can start first with the lady, please, if you can. Then,
coming from STC. I just want to ask a question, especially to Dr. Menilas. We appreciated this 4x4 strategy, and especially when it goes to in-service training. And we already know that there is a shortage of health professionals already. And there is a plan to make training for those who are in service to improve on their knowledge, for them to be able to deliver on the required quality. My question is, what are the strategies as the Minister of Health so that by taking this process, it doesn't compromise the quality of services, as we take some of health professionals to go to school, or we require those who experienced medical doctors to go to train them for a while. They are going to be out of the hospitals, the health facilities. But what are the strategies for the Ministry of Health that this process is not going to affect the quality of services
while those professionals are away taking studies. Thank you.
Please.
Yeah.
Terminals.
Yes, thank you. Thank you, Ms. Amy. One stone, two birds. Like the way it is built, it will take care of many challenges that we have had in the past. Maybe to clarify, the 4x4 strategy, we are actually prioritizing the local program. We strengthen the existing local program, and we co-create with the partners new programs that we need of today. On top of that, this program, as you know, traditionally we have been having like 4 teaching hospitals. Along with the 4x4 strategy, we are having 10 newly selected level 2 teaching hospitals that we have to strengthen, which means they are going to have the right equipment, they are going to have more access to faculty members at all levels, they are going to have the infrastructure expanded to meet the needs of the 4x4 reform, and the staff that are there, they are going to benefit to have that learning environment that is improved. And the long-term vision is everywhere we have a hospital, they should be prepared. We are talking about the 4 traditional training hospitals and the 10 level teaching hospitals. On the long run, every hospital should develop that model. You are touching on the medical missions that we have been having in Rwanda. They have to be adjusted. In the past, it's about 10 to 20 patients treated, operated for this and that because they couldn't, it's expensive to have them travel to India, Israel to have heart surgery. We do it locally. They will make sure that their mission also have the training component. So missions that don't have training component in it, they are more and more unacceptable. So we are improving locally, and this is benefiting the health workforce at large.
Very good. I think I see the hand.
Yes.
I see the hands, Dr. Brian. Please go on.
Thank you very much. 2 quick questions. One to Dr. Menelas. You did talk quite a bit about retention, but what I haven't been hearing is about the non-financial. So the financial incentives, I think, have been mentioned. But are we putting emphasis also on non-financial incentives? For example, if I agree to go and work in a remote area, I have more opportunities to go for training that is supported and other, in addition, for example, to loans, etc. Then to Dr. Nkika Bahizi. Again, incentives. You did talk about incentives, but as the private sector, I just wanted to also hear what you are doing to give back to the community. And secondly, and that could include private doctors volunteering their time, particularly in facilities that are more stressed, in some of the experts, because we know some areas have problems getting experts because we don't have the experts from government there. And then also another way is to adapt, which I've had in a number of countries. Private sector adopting a health facility, adopting a ward, adopting a hospital, and supporting them, basically working with that institution to help them to address some of their gaps. Is that something that the RMA is considering to do? Thank you.
Please, Doctor.
Yes, thank you very much, Dr. Brian. Yes, the reform around welfare is also touching mainly on the non-financial motivation strategy. And we have looked at a number of them, such as said by Dr. Fulgence, creating a favorable environment to have the health workforce access the loans in a way that is much easier, as we see in the education sector. The teachers have a framework that is very well done, and this is one way to motivate the health workforce. Issues related to the housing, transportation, they are going to be delivered as a package. You can imagine if you are sent in an area where you have not worked before, you need somewhere to stay, you need to be able to reach that place, either by facilitating the private transportation, commuter transportation. We have several models that we can we can refer to, and also looking at waiving some of the student loans, for example. And this could be interesting for the health workforce. And when we send them out there, we don't forget them. For instance, when we have, we call for application for scholarship for higher education, like continued learning at residency or fellowship, we make sure that we don't take the candidates primarily from Kigali. Actually, we start from the periphery. We put where we make them feel like we have not forgotten them. As opportunity come, they are going to be a priority, and many, many others that you are going to discover. Yeah.
Thank you, Dr. Brian. Interesting questions you asked it for. I may start on something I didn't comment on. If you are asking those facilitations, but what is the role of healthcare professionals? I didn't have time to mention. I may need more time, but simply, health professionals have their role in what we are discussing here. Starting from basic things, efficient use of resources. I remember when we were being trained in the operating theater, one of the surgeons was teaching us how to minimize loss of resources. If you are suturing, do not throw a big proportion of the suture in the garbage. So from there is a good and important contribution of health care professionals by entertaining expenses in what the government or partners are investing just to promote or improve our health care conditions, working conditions. Now, as Rwanda Medical Association, yes, it is a bit private, and our contribution to the community, we have many activities. I can mention one regarding prevention. So, as we are not yet of a big number, but we are doing it downwards from the hospital, from the health facilities, going at the health centers to teach and interact with the community members, teach the population how to prevent disease, how to promote their health. So we don't want to wait until sick people come at the health facility, but we anticipate by prevention. About the private time for example, doctors, we don't do it alone, but we do it with other members of the community, different specialties like orthopedics or ENT or GYN. There is what we call outreach. For example, specialists can leave those university teaching hospitals and reach the community nearby their living places and provide specialized health care. Currently, it is not yet like voluntary as it can be, but I think when we have more human resources, people may have enough time, free time, to provide health care as voluntary, but now they are a bit compensate with facilitation on the ground. So at the end, we wish that we may really provide a portion of our time to the community in return of what the community and the country invest in our education and our development. Thanks.
Thank you very much, Doctor. I think for the sake of time, I would like to thank you, our panelists. I think it was a very rich discussion. I hope also for you it was very informative. And thank you very much. A round of applause for our panelists.
Let's appreciate that panel one more time. Thank you. Thank you very much. It was very incisive, and indeed we did pick so much from it. And I want us now to move to our next item on the program, which is lunch. And so lunch will be served. There's a very amazing tent in this area. And we have amazing ushers who will guide you in the event that you need support in that area. Because we are now late on our program, I think we can be able to say maybe by around 2:30, 2:40. Yeah, 2:30. Yeah, because we've lost a whole hour, so we need to recover that. And I want to appreciate that because it comes from someone she knows what she's saying. And it's very, very good. So please let us do that. And then also there's a QR code. If you see it anywhere, I'm told it will be projected on the screen, but that's not the QR code. But they might project it. When they do, or if you see it on any of the documents, please, you can scan your phone and be able to register, because the teams would love to get in touch with you and share very necessary and important resources for you. So I want us to go for lunch. I've been told that everything is amazing, so eat everything. And everything there is highly recommended by health professionals. Bon appetit. See you Mkanya. Let's go now. Let's go. Thank you. I know bonjour, I know je vais de l'eau. And then there's bon après appétit. That doesn't exist. Bon après appétit. It is a rest time. So bon après appétit to all of you. I hope you enjoyed the meal. I hope it was as you had expected or it beat your expectations. I want us to delve deeper into the next session because we do not have much time based on the program, and later on there's a gala dinner which we need to freshen up and get our dancing shoes. So we need that transition time. So I want to call upon the moderator for this amazing session. And the session is going to be revolving around improving quality of care through access to medical technology and digitization process. This is a very interesting panel that will be moderated by the Head of Planning, Strategic Information and Health Financing at the Ministry of Health. That is none other than Dr. Mohamed Semakula. Let's appreciate him as he comes, ladies and gentlemen. And then we'll... did you guys have lunch? Yeah. Wonderful. Okay.
Thank you. Great, thank you very much. We are going to have a very interesting session, which is going to entitled Improving Quality of Care Through Access to Medical Technology and Digitalization Processes. We do believe that fasting the digitalization can increase access to the services, especially in remote areas or in a situation where we don't have enough human resources. So through technology, people can still access services. Therefore, I would like to invite my panelist, Mr. Chizere from Fourth Industrial Revolution, working with Minister of ICT. Mrs. Laisa Mahoro from IRCAD. Engineer Francine Mutesi from RBC. Antoine Severa from RISA. And lastly, Mr. Mugumya Silver from Ministry of Health. So, thank you very much. This session is a very important session. I just want to give each of the panelists just 1 minute to introduce himself, and then we will proceed with the discussion as planned. Let's start with Chizel.
There we go. Thank you, Dr. Mohamed. My name is Joris Chizere, and I lead strategy at the Center for the Fourth Industrial Revolution in Rwanda. We are advising the government of Rwanda through the Ministry of ICT and Innovation on issues around artificial intelligence and data. And that looks at both policy interventions that the government should put in place to create an enabling environment for innovation in AI and data, but also looking at specific application areas where AI can play a role in different sectors, with healthcare being one of our priority sectors. Great to be here and good to be part of this conversation.
Thank you. Yes, Raisa.
Hello, my name is Raisa Mahoro. I'm the training manager at IRCAD Africa. IRCAD Africa is a training center in minimally invasive surgery. So we focus on trainings and also research. Without going into more details, because I'm sure we'll get into it, that's pretty much it.
Thank you. My name is Francine Mutesi. I'm a biomedical engineer, and I work at RBC as manager of medical technology and infrastructure. division, and we are in charge of medical technology projects and coordination and supervising construction of healthcare facilities. Thank you.
Thank you. Thank you very much. I'm Silver Mugumya. I'm from the Ministry of Health. I'm the IT business analyst. Part of my role is leading the digital transformation, and part of the main projects includes the digitalization of healthcare services, and also making sure that the interoperability and the exchange of data between health facilities and healthcare professionals are working correctly. My background is from the e-government and e-health, so I'm the right person for the investing in the healthcare services, digital platforms, and all of that. So I would be happy to consume the other $100,000 for making change for the healthcare services. Thank you.
No, thank you very much. Indeed, Rwanda has invested a lot in digitalizing the health system over time.
Availing those equipment needed at all levels, meaning that if Rwanda has already established the healthcare facility levels, we know which service package is provided at health center level. We know which service is provided at the district level and upwards. So if we can ensure sufficient medical technologies are available, if we can ensure that we have smart, innovative, sustainable infrastructure, ensuring basic infrastructure. Earlier, they were talking about safe water, ensuring that we have safe electricity, properly installed HVAC systems to ensure IPC is respected, ensuring that the patient flow is respected, providing medical oxygen systems which are well installed. Those are the things we want to address, have proper infrastructure, proper healthcare technologies, and then move towards providing the best healthcare to our people. So the alternative financing for this strategy is very key. And I hear that there is a gala to discuss with the private sector. For sure, this will be interesting to hear what you guys can bring in to support the ministry. Thank you.
Thank you, Francine. Indeed, as you said, apart the infrastructure, we do also have issue in terms of the human resources. Recently, Rwanda launched IRCAD Africa to contribute in terms of capacity building in high-end technology, using high-end technology, especially in surgical area. So, Raisa, what can we expect from IRCAD in terms of contributing to ensure to build the human resources in surgery here in Rwanda?
Thank you, Dr. Mohamed. So as I had previously said, IRCAD Africa is a training and research center in minimally invasive surgery. So those are our two main focus. So to just start with the research part of it, we made sure that we have a research team here on ground that is able to work with the healthcare professionals. Why? Because we want that the research team is able to work hand in hand with the healthcare professionals and see what issues they face in their everyday life, and be able to come up with solutions using technology, AI, mostly, to solve those issues. And right now we have our team that's working on a 5-year project that started in 2020. The project was put together with the engineers, of course, but also the doctors here in Rwanda and in other parts of the continent. And the idea is to come up with a diagnostic application that's going to be able to be put in an ultrasound, affordable ultrasound, that can be used by healthcare professionals that don't have to be specialists. So that helps us resolve the issue that we have in terms of specialized healthcare professional. Not only healthcare professional, but specialized one. So that ultrasound will be able to, we will be able to distribute it throughout the country and the continent, and people with minimal training will be able to do it, and some diagnosis will be done earlier on instead of having to wait for people to go see a specialist. So now, in terms of trainings, we have training programs which are focused in minimally invasive surgery. So one might ask the question, why minimally invasive surgery? But we have the Western world which has embraced minimally invasive surgery decades ago. It's only starting to be prominent on the continent now, but it has a lot of benefit in terms of outcome, be for the patients, but also for the healthcare system at large. Right now that we have limited resources in terms of healthcare professional, when we train them in minimally invasive surgery, it helps us make them more efficient, because in terms of outcome, we have them being able to do more procedures, having patients not staying in hospital for as long as they would have stayed with open surgery. So that's what I would say IRCAD Africa will be bringing. So, and the good thing about IRCAD Africa is we're not only focused on Rwanda. Yes, we're going to be resolving the issues that we have here on ground, but we're targeting the entire continent in terms of trainings of professional, because the issues that we have in terms of healthcare professional here in Rwanda is very similar to the ones that we're going to find in the region. Thank you.
Thank you very much. So that's interesting that you're using AI right here from Chizere about how can we accelerate access to the high-quality healthcare in Rwanda through, especially on the community-based work services, how that one can be linked with AI to ensure the quality of services at community level.
Yeah, thank you, Doctor. So there's a lot of promise for AI in healthcare, specifically in our setting, specifically. And
maybe you can also tell us what is AI.
Yeah, I was going to say. So maybe let's start there. So artificial intelligence is basically, it's a broad term that means the ability for machines to do things that are typically associated with humans being able to do. So, for example, we're able to see, and so there's a field of artificial intelligence called machine vision, which is basically how computers are able to look at a room like this and say there's, okay, about 100, 150 people, there's a bunch of tables and so on. Or the fact that we're able to converse, so natural language processing. You can say a word to me, or you can write a text to me. I'm able to read it and make some context or make some judgment about what you're trying to tell me to do. And so machines are also able to do that, increasingly so with innovations like ChatGPT, for example, that we're going to talk about in a little bit. So it's, broadly speaking, the ability for machines to replicate the same senses or the same actions, activities that humans are, that typically are traditionally associated with humans only. And so maybe before we go into some of the benefits and some of the use cases that we're excited about, also want to say that, I know there's a lot of fear, of course, and around the different risks associated with AI. One of in the homes of patients without having to come to the hospital necessarily. So can you give, can you take a picture, for example, of somebody's skin, and can the AI predict if that somebody has skin cancer, for example, which is also another emerging use case that we're seeing. So diagnosis as a broad section is quite exciting. There's a lot of investment or a lot of innovations that are happening. The next field related to that, to diagnosis, is around clinical decision support. So essentially the ability for machines to be able to assist a doctor, a nurse, a community health worker as they go about making their clinical decision. So ChatGPT, which I think people might be familiar with at this point, previous versions of ChatGPT showed ability to be able to answer, to get the right differential diagnosis about 88% of the time. This is as of a year ago, which was compared to about 20-30% to people that work in the healthcare setting but aren't clinically trained. Now, that is still worse than a GP, which is in the 90s plus, but it's very, very important and very interesting when you think about it in our setting where we have these community leaders, community health workers that are performing a lot of clinical work but aren't necessarily clinically trained like a doctor would be. And so if you're able to give them access to ChatGPT, for example, other versions of large language models, then you can imagine they might be able to do a lot better, a lot more efficiently, may be able to detect high priority cases sooner than they previously would have been able to do, and then be able to triage these cases to the appropriate medical facilities. So clinical decision support is another quite exciting area. And then there's a broad area around, how do I call it, essentially learning and discovery and knowledge. And so if Dr. Semakula is sitting in the planning department at the MOH, how does he determine that, okay, we need to have more beds in this part of Rwanda, we need to have more medicine of this type in this part of Rwanda versus the other, we need more nurses in this part of Rwanda versus the other. The ability to give all these huge amounts of data to AI and for it to be able to make quick decisions and give good insights that can be used by decision makers is also quite exciting. And beyond sort of like public decision making, there's also the ability to learn about diseases and other ailments in ways that we have been able to do previously. So for example, can you do a combination of genetic data, environmental data, clinical data, and so on, to learn about malaria in a more effective way, to learn about drug resistance to malaria in a more effective way, and can you use that to come up with new drugs, new vaccines, and so on, that may help us eradicate some of these very big diseases. And then beyond, things in the clinical aspect, there's also a lot of efficiency gains that AI can bring in the healthcare sector, broadly speaking, whether it's around helping doctors take notes. So there's a bunch of voice medical note-taking technologies that we're seeing come up. So you're having a conversation with your patient, you don't have to write a lot of things, and the AI is capturing your conversation and making a clinical note for you, which could then, for example, reduce the amount of time that a doctor has to go writing notes and putting it in the computer and so on. Or whether it's about predicting supplies, like a former colleague on the panel was talking about. So there's a bunch of things we're excited about in the clinical setting, but also a lot of potential efficiency gains in the healthcare system, more broadly speaking, that are very interesting, and we're looking forward to seeing more of happen in Rwanda.
So thank you very much. Maybe before taking another round of questions, I would like also to engage audience to ask any of the question to any of the panelists before I come up with the final list of questions. Yes.
Thank you. My name is Jules Mogisha. I work for Rwanda. I want to thank the panelists, but I have some few questions for them. How can healthcare providers ensure the adoption of this technology doesn't compromise the human touch and personalized care that patients expect? Another one is, what are the considerations for ensuring data privacy and security in the context of this digitized healthcare system? And the last one, we go to the AI personnel. The question is, what are the safety and ethical considerations that healthcare organizations should take into account when implementing this AI technology? And how can this be effectively mitigated to ensure patient safety and data privacy? Thank you.
So thank you very much. Let's have 3 questions. Then the first one, Dr. Veronique, and then...
Thank you very much. I'm Dr. Veronica Mugisha from ICAP. As I was following up, I realized that actually we have had an experience in using, I don't know whether it is artificial intelligence or technology, for providing health care. You all recall that in 2020, maybe beginning March, and a couple of months thereafter, we are receiving healthcare from home, remotely. We are being diagnosed remotely. We are, I think, getting our prescriptions remotely, something like that. I'm just curious to know, what lessons have we learned? I think that was a good experience that it can be done. And I don't know if there has been some evaluation, for example, to look at the quality of care. Did we have more mortality related to the non-COVID related mortality, that is, because people were receiving their diagnosis and care remotely, or not? I'm curious to know, because if, for example, it turns out that data shows us that in spite of people receiving care remotely and consultations remotely, if the mortality did not increase, or if the quality of care remained the same, then I think it is a good thing to adopt. We know it is doable. Thank you.
Thank you very much. Yes.
Thank you. I had a question I would like to ask the CEO of RSSB, but I take also opportunity to ask this question to Mr. Silve, who mentioned among the other responsibilities, he's focusing on ensuring interoperability of system within MOH. So my understanding is for a patient to get good service, good health service, it's not only to look about system within health, the Ministry of Health. For example, if you take the issue of community-based insurance, if patients go to the hospital, to the health center, and maybe a name is, there's something wrong with the name, so they will say, go back and check, correct the name with the National ID Agency, or they say your social category of the category is not correct. So, and you see that in that case, a patient can lose life or not feel comfortable or appreciate the service, the quality of service he or she's getting. If there is no, nothing is done to harmonize the system, not only within the Ministry of Health, but also with other ministries, whatever the ministry, it can be the Ministry of Local Governance, to look at what the system that also speak to our own system at the Ministry of Health or other system at the health facilities. So what is the effort of the Ministry of Health to harmonize or to work on that, to make sure that different systems that have to give information about the patients before he or she gets service, speaking to each other, is easy to correct things or easy to give service to that patient, even without saying go back and come back, correct this. So this is the first question. And the second question goes to engineer, Madam Francine. I just want to, I heard that there is some measures to make sure that the procurement is done based on the needs. When you see it's just about other existing equipment within the facilities, you may find that there is equipment, new reports, but it is not going to take up to 3 months or 6 months, then it is stuck, it doesn't work. So what are the measures within RBC that you reduce this momentum that we keep on having increased number of equipment which do not last before they get problems? Another question is, what are the strategies in place that you the RBC can empower the health facilities to be able to provide the maintenance themselves without being stuck until they wait for RBC to provide. And in that time also the patient cannot give services if those equipment are not working. Thank you.
Thank you. Those are great questions. Let's first hear from the panelists, try to respond one by one. So let's start with Sylvain, then we go to Francine. But any panelist who feel like can jump in, please feel free anytime.
Yeah, thank you very much, Doctor. Yeah, thank you for the very good questions. If you allow, I may start by the last question was very, very interesting, and it is really painful to see the patient himself coordinating the care. And this patient is sick. He's seeking for the care, and we are also the one telling him, go here, come here, go here. We have seen this as a pain point, and it was the starting of digital transformation strategy. This was in the 2020 that we started at least changing this behavior of a patient coordinating the care. As she mentioned, it was correct that at a given point, the patient could even be at the hospital, and the hospital sends him to an insurance for approval. So you can imagine a sick patient going to the insurance and then go to the queue and seek for, please, can you allow the hospital to write for me this medication? So this has been seen as a pain point for all the government. And with my mini ICT and Ministry of Health, we have started creating the interoperability layer, and this interoperability layer we started with we have a government enterprise service bus that is going to help all the systems in the government talk to each other, and this is going to be helping all the citizens to see the government as one institution. So I used to give an example of where you are asked when you are going to start a job, they are asking you to bring the testimonial that you have not been imprisoned, and you know, there is no private prison, so the government is the one who can have prisons, and they are asking you to go and testify that you have not been in prison. So they still have data, and they're asking you to bring again the data. So we are trying to work together, to put together all of these systems to work together, but specifically in health, we have created what we call Rwanda Health Information Exchange. This is a very great initiative that we have embarked in 2021, and we are at a good stage of testing now. We are in the piloting stage. So where you, as a patient, you are uniquely identified in the country, and you will not need to repeat your name when you go to the next level. And this starts from your nearest community health worker at the village. So when you go to the community health worker with his smartphone that we have started also distributing these days, so he will be able to give you a unique patient ID. And when you go to the next level, I mean the health post, the health center, so they will not ask you what's your name. So at least they could be able to see the history of what has happened, what happened to the previous episode from the community. And this will continue until the end of your episode, the end of your health. It can be possible that a patient moves from all the steps until the specialized hospitals. And this also helps the Ministry of Health to connect to the insurance. So it has been a pain point also for claims management, and this also has been taking time. So with having a patient unique, with having standards talking the same language, the next point we are creating now, it's an integrated insurance portal where all the insurances are putting together the data. So the Ministry of Health, on behalf of health facilities, we are having all the insurances data, so the facility needs to connect to the Ministry of Health and know that this patient is really is a valid insurer, is valid and is insured, and he's having this policy, means he's paying 10%, 15%, and this is going to help the interoperability between facilities, between the insurance, and this is going to ease the claims. So going to the harmonization, the effort that we are doing, of course, we are harmonizing, making one patient, but also we are supporting our healthcare providers to take right decisions. So you can imagine the patient that you are seeing today at the specialized hospital, and you don't know what happens before. The decision that you will take, so you need to repeat most of the exams that has been done before. And this makes a patient to pay, this makes a patient to delay, and all of this contributes to not providing a well healthcare service. So we have created this single point where the patient has a unique file in the country, and all the steps that he's making, his longitudinal data is also making, is putting on the file. And then whenever he reaches you at the specialized hospital, you will be able to view all the past history, and then you can take the right decision. Then going to COVID example from Dr. Veronica. This is a very good example. And this is an experience that we could share as Rwanda. So during the COVID time, with using the digital tools, we could provide the data in the morning, we could provide data at noon, and we could provide also data in the evening. And this has made our policymakers to be able to take very good decisions, I mean quick decisions, because in this time we needed quick decisions to know where do we lock, where do we have many people that are infected, where do we need to vaccinate mostly, where do we have people that we need to intervene as quickly as possible. So I think you are asking the research on what was the quality of outcome, and I think it is a very valid point that we should leverage on this initiative that was started in these hectic times, and then we are now in the good times, but we can still access this patient remotely. We can still have this patient also provided care without just making them coming to the hospital. Remote consultations can also work. We have a very good example with Babil has made very good consultations online, and it has improved the care services. I think that's what I had noted for me. The UDH and national ID, people going home because their UDH is not working. So we have put together all these systems, and I think soon you will be seeing the results. We have already connected about 100 health facilities. Like today, we have taken a use case of HIV patient, where we have managed to coordinate all of these 100 facilities. So when you are like in one of these facilities and you are moving to another facility, they will not be able to ask you anything because they can see what medication were you taking, what was your viral load level that you had previously. So they can continue serving you like you were their patient. So this use case is going to continue to OPD and other cases, and we hope that this interoperability is going to be solving most of these painful points of the patient journey. Thank you.
Thank you. Indeed, digitalizing the health system, especially basing on digitalizing the patient pathway, that will contribute to efficiency in terms of accessing healthcare. So, Francine, can you go on with questions?
Thank you so much, Dr. Mohammed. Thank you for asking your question. The first question is about equipment stuck after being installed in hospitals. That is true. We've had, the reason why we are changing strategies is because we've had challenges in healthcare technology management in our hospitals, not only due to the fact that we have a limited number of biomedical technicians who are in hospitals and who are qualified enough to handle that. But we've had also some challenges getting partners or maintenance contractors who are reliable, who can avail spare parts timely, who can respond timely. So over the last few years, we've contracted some local companies, but still we are still having downtime. If an equipment has an issue, there is a long time to wait before it's maintained. So some of the strategies I mentioned earlier, the strategic acquisition partnership scheme, it's coming to solve this challenge. Meaning that if we buy, let's say, ultrasound machine from company X, we are going to enter into a partnership with them so that they can handle not only supply, deliver, install, commission. This was being done before, and then they would train the end users and leave. We want to continue with them so that they can build capacity of biomedical technicians in hospitals to handle at least the preventive maintenance, be able to do minimum repairs on the machines, and then have a relationship with them to have spare parts delivered timely when they are needed, or even perhaps have local storage of those spare parts which are mostly needed. And then one of the major item is to have management over the lifetime of the equipment, not only for 1 year, for 2 years, but have a contract that goes up to the end of the lifetime of the equipment, which means that if we tackle that for a given service, then we'll be sure that we have a functioning service, we have functioning equipment in this department, and we only will be waiting to monitor, supervise, and see how it's being implemented. Another strategy which speaks to this is the 4x4 strategy mentioned earlier. We have a component of capacity building, which also will help train sufficient biomedical technicians, biomedical engineers, and there is a discussion to strengthen and build a bigger team, a bigger technical team, which is capable of not only managing the equipment in hospitals, but also maintaining, repairing them, and being able basically to assure a continuity of services in hospitals. So it's an ongoing effort, but these two strategies are here to solve that challenge. We do have, though, a short-term solution which we are using. It's a bit costly. It's continuing to hire local contractors to maintain these hospital equipment. We are trying to collaborate with them, help them better serve us by having local storages of spare parts, having technicians on their teams. This is a requirement so that we know that at least they can do the minimum to help us continue the services. Thank you.
Thank you, Francine. I think that is part of the 4x4 strategy, which is increasing the strategic acquisition. It takes also into consideration the capacity building, but also thinking on the local manufacture of some of the equipment to ensure the availability of service and the capability in the country. So going on AI questions, Chizere, can you tell us a little bit, respond to the questions related to AI?
Yeah, I think the one question that was directed to me was around safety/ethical principles of AI in healthcare specifically. So I'll try to answer that. So in terms of like what are some of the safety and ethical principles, there's a few which range from things like safety, for example. So you have to make sure that the systems you're creating don't produce unavoidable harm to humans. To things like accountability. So somebody in your organization somebody must have the responsibility to govern any AI systems you might be deploying. The different diagnoses or chats or conversations that the AI systems have must be auditable. So that's sort of like what the accountability principle mean. It also includes things like transparency. So it must always be clear that if somebody is engaging with an AI system, they must always know that they are engaging with an AI system. The AI system must be clear on what it is it's able to do and not able to do, and it must be able to give that information to the person who's engaging with the system. It also includes things like data privacy, data security, and so on. So there's many different ethical principles that are advisable to keep for companies that are developing AI tools to keep in mind. And so what we've been doing in Rwanda, there's an example that's given of Babil. So Babil had an AI triage tool, which basically asks you a bunch of questions. How old are you? Have you been sick before? What are the different symptoms you have? And it tries to come up with a decision on how to triage you. So should you go see a nurse? Should you see a patient? Or are you fine and can you wait? So when they were building their tool, we helped them define what these principles mean. So literally writing down, okay, for accountability, these are the different questions you have to answer at every stage of your development, whether it's creating the requirements, developing, deploying, and testing. So helping them put in place all the different questions that they must answer at every step of creating an AI, or the AI tool in this case, the different questions they must answer at every step of that to make sure that they're developing ethically. So that's sort of like how we're thinking about it and how companies that are creating AI tools are thinking about it. The question becomes, how do you actually enforce it? How do you make sure that companies are actually doing this? So what's the role of the government in this particular case to regulate AI, basically? And there's, the jury's still out around what's the best way to do it. I think different countries are taking different approaches. In Rwanda, what we've done is we've created national AI ethical guidelines, which are documents that RURA, the tech regulator, should be putting out soon. And essentially, it's not a binding document for right now. It's a document that says, okay, if you're creating an AI tool, there are different things you have to abide by. Now, of course, there's still a question of what's the appropriate lens, what's the appropriate position or approach should the government take in order to ensure that the systems are being created in a safe way, but of course not kill innovation and create enough space for researchers, innovators to be able to come up with interesting products. So that is sort of like how we're thinking about it. But the biggest question, like I said, is around how do you actually regulate it? How do you actually enforce it? How do you make sure the companies are following these things? And beyond that, actually, how do you do that across countries? So if Europe regulates in a different way than Africa does, or than Rwanda does, than America, than China does, how do you make sure that the appropriate ethical principles or guidelines are being followed in the relative geographies? So those two are the challenging issues around regulating AI and ethical principles and so on. I hope that answers the question.
Yeah, thank you very much. I want to give audience one more question before we conclude. And I would prefer anyone who raised the hand first, then if you're still, okay, yes.
Thank you. I would like to ask him my question in French, but as I don't see equipment there for those panelists, let me try in my small English. My question is that for this technology of intellectual artificial intellectual. Bon, let me. Okay. So. Okay, ça va. Bon, alors pour la technologie, l'intelligence artificielle, souvent ces technologies, des fois, ça coûte cher. Raison pour laquelle je me demande le coût que ça va prendre au niveau de couches de la population et qui ne dispose pas de moyens suffisants. Est-ce que réellement ça va parvenir à aider la population et ça va aider la population et à parvenir à être soignée sans problème. Donc, à considérer le coût que ça peut prendre, c'est ça.
Okay.
I think that was to me as well, right?
Yes.
Yeah, I was gonna suggest.
You want me to translate, or you understand?
I was gonna say he could have used Google Translate, another AI, another AI to translate the question and read it out. But I think I got it. Let me know if so. I think what you were asking was around. The technology is quite expensive, and there's a lot of people who might not have the means to be able to essentially access it. If I got the question correct, so that's a very good question. So maybe to start with that of people being able to access the technology. So it's true that we do have issues around access to smartphones that are still quite expensive. Internet is not affordable to everyone, so that's a challenge that we unfortunately are faced by. Now there's some creative ways, some innovative ways that technology innovators are coming up with to be able to serve this population still. So things like offline apps, which are basically applications that don't require internet every time. So you can use it offline, it can tell you a bunch of different things, and when you do get access to internet, maybe you can upload the data and so on. I think, I don't know if, I think this is a similar infrastructure you're using with some of the apps you're creating, so maybe Sylvain can talk a little bit more about that. But there's also using things like voice. Voice is a very interesting application, which means like usually for me, I will go to Google, for example, to engage with internet. But can you create a hotline, for example, that's connected to the internet in the back that somebody can call, and the hotline will basically do the internet stuff and then repeat back a question or an answer to whoever is calling using a regular phone. Now, that said, so I guess what I'm trying to say there is like, there's some creative ways that innovators are coming up with to be able to serve these communities. The larger question, though, still with these communities is there's a question of how do you actually create the need for the average person, whether it's a community health worker or the average Rwandan or average African, how do you create the need, the demand for them to actually want to have a smartphone, to actually want to have internet or invest in internet? If you're in some city in Europe or in North America, you probably should or need to have a smartphone because you're gonna need it to get access to your bank, need it to call an Uber, need it to order food and so on. If you're in some village somewhere, you don't really necessarily have to have a smartphone because you can do pretty much everything you need to do without a smartphone. But if we start to create tools, applications that actually are useful for a farmer, for example, if you can help a farmer increase their yield by so much, it might make more sense for them to actually make that investment in owning a phone. If you can do the same for a community health worker, it might make more sense for the MOH, community health workers, to invest in these things. So there's a big question around how do we think creatively around where the value actually is, what can AI do for us, and how to create products that actually unlock that. And we think that in so doing, in creating those products that actually people need, you're going to create the demand for these products and in turn hopefully help answer some of the questions around smartphone penetration and internet and so on. Now the other big question though that you didn't talk about, but it's very important from a cost perspective, is the investments that are required to actually create these AI products. So investments in data, how do you make sure that you have enough data in the right form that people can use to create AI products? There's a lot of investments in computing infrastructure, so making sure that you have, basically computers that can be able to process this data and come up with these products. So the data aspect, the compute aspect is very, very key as well as a big cost factor to this, which is currently limiting our ability to create a lot of these things. Now that said, there's some ways around that as well. You don't have to create everything from scratch, so you can use a model that somebody has created before. So there's some ways around that as well, but the data and computing infrastructure aspects of cost are big problems, big questions that we face in Africa more intently than in other parts of the world. So yeah.
Yeah, thank you very much for the clear explanation. That's one. Maybe to wrap up with this session, let's look technology and the AI as enabler to access services.
especially in our context when you look at the developing countries that are struggling with infrastructure, struggling with the human resource, struggling with remote areas. In this situation, digitalizing our system, having a system that can enable to get consultation when you are at home, that will contribute a lot in terms of improving access to healthcare. Dr. Veronica talked about the COVID period where people were accessing care when they're at home. But not only that one, with the limited resource of the human resource that we are having, when we have the right tools, you can provide services to several people, and they don't need to go where they are. And that one is an opportunity that we need to grab using this technology. Currently, we are talking about the community health workers that we are having. Remember, those are professionals. I mean, those are non-professional medical trained, but those are people we are training. Can we imagine if we can give them the tool that are empowered with AI in order to take their decisions? They will be more accurate in providing the services that they are giving. And that's really very important. It's an opportunity that we need to look at it. A community health worker having a tool that will just help him to take a decision if this person has this particular disease or not, or just take a photo and see the symptom and get some details about that one. That one can help to access services to so many people without having the professional medical doctors everywhere, especially when you know that training a medical doctor takes time. You are talking about 6 years period to have a medical doctor. So having this tool accurately, AI, digitalizing our system, at least can be alternative. Currently in developing countries, digitalization of our health system and the AI, it's not a necessity, but it's vital because it can save lives. Thank you very much for attending this session, and thank you, the panelists, for your contribution.
Thank you very much. Well done, especially having a panel like that after we've been fed very well. Well done. I want us to do one very important thing. All of us, please, on our feet. Just for 1 second. Just stand up. I know you're saying seriously. Oh, you're saying thank you.
Thank you, thank you, thank you, thank you. I think what you didn't explain is how to do two. And I don't know if anybody got to figure out how to do 2. I was trying to do 2 like this. How do you write 2 with your body? But thank you so much. Dr. Mohammed, I didn't want your session to finish because it was such an interesting discussion and really where the future is. So congratulations to that entire panel and the team who are there having this discussion. And thank you for leading on this digitalization and AI. And whenever we land in Rwanda and we go down the stairs in Kigali at the airport, we're met by that robot to remind us that this is how technology is taking over or part of our lives. So I have an interesting session, but I'm building on the session from the morning. So I have the advantage of not having to give you any story before because you're good students and I know you learned everything about this in the morning. So now we're just going to chat. And so I would like you, as I call the speakers up, I would like you, as you sit where you are, to ask yourself a question. If you had one solution to provide, just one, in terms of how to raise more resources, what would that be? And then I'll give you a chance. I wish we had Mentimeters or whatever. We could do chap, 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 chap like this, and we would have answers because we need your suggestions. What are your ideas? What are your solutions? So be thinking about it and maybe write it down, and we'll do a rapid fire, see how many solutions we can catch from the room when we have a minute. But let me introduce my panelists so you can come up. I think you know Dr. Calypso, who was already up here, Chalkidu. Let's see whether we're good with the pronunciations. Dr. Calypso, welcome up here. She's the head of health financing at the Global Fund. We have Dr. Gilbert Biraro. Dr. Gilbert, are you here? Dr. Gilbert, he's here, going once, going twice. SPIU coordinator, Rwanda Biomedical Center. I think he just walked across the road. I think your offices are right there, right? So he just walked across the road, so he's got energy. Dr. Veronica Mugisha, please join us. You were asking good questions from ICAP, country director for ICAP. Mrs. Nolit Kabanyana, also from the Rwanda NGO Forum. Please join us up here. I have bios, but my sense is that we don't need to read bios. I think the only one that I will stress is that Dr. Nolit Kabanyana has been a champion for health communities for over 10 years. And this is the Rwanda NGO Forum on HIV and health promotion. So I'll mention that. And then I think I'll call my colleague Hind Hassan, who is the country director for UNAIDS. So she's my colleague's sister here. Wonderful to have you up here. So we're really going back to that discussion we had this morning about how are we going to sustain the HIV response? How are we going to sustain the financing? You heard a couple of figures that we threw around where we were saying, even though the costs are down, and Dr. Calypso was sharing that even though the costs are not as high as they may be for other drugs, we know that I think our average price right now for ARVs is $89. Is it about $89, I think, per person? And with 16 million people on treatment, you can do the maths. If we do 100, it's 1.6 billion. So it's already really, really, really high. If we look at what that means for Rwanda, we can break it down, and we have the RBC here to be able to give us a real sense of what it's costing us, what it's costing Rwanda, and how it is that we're going to be able to move. So we want to deepen our knowledge on this subject, get a little bit deeper around how are we going to actually move this needle in terms of HIV financing. Some of you might ask, why are we focusing on HIV when there's so many other diseases? The truth of it is that for many of our countries, the HIV investment from countries that is required is anywhere between 10 to 30%, depending on the country and depending on the burden of the disease. And so, but also, as I said earlier, what we have learned from HIV and the systems that we've built are very helpful for other systems. So it's really important for us not just to sustain it, but also to take advantage of building these systems so that they help with other diseases. So let me start with you, Dr. Gilbert. You've already achieved 15.8%, at least overall health financing. I know that for us with HIV, there's still some gaps, and I know in other areas, even if you've achieved the 15.8%, there are still gaps. And maybe help us to understand what some of those gaps are. But my first question would be, what strategy are we adopting, is Rwanda adopting, to ensure this adequate domestic financing as we seek to reach the 2030 target of ending AIDS by 2030? And then the second question is about allocative and technical efficiencies, and how is that working out? I think we heard about that a little bit in the digital session, but over to you, Dr. Gilbert. We don't have a lot of time as it stands. You know, so I think because I'm a woman moderator, they took time from me. So we'll come back and discuss gender inequalities on moderation. But let's start with you, Gilbert, see how we go.
My apologies.
So I'll ask us to just do a quick 5 minutes as I ask you the question, so we have time to come back. So go ahead, Dr. Gilbert.
So thank you so much. And my apologies on behalf of the organizing team for stealing your time. So over the past few years, actually, Rwanda has been hailed as one of the countries that have really done well in the control of the HIV epidemic. We've been implementing different strategies. I think one of the strategies is that Rwanda has been increasing its domestic resources. So over the past few years, we've seen government of Rwanda putting in more money into the interventions of the HIV program. This will really help to reduce on the burden of external financing, although this is not also easy. One of the other things that we've really done well that has helped the program is also to integration of services. So we've been able to integrate services into the broader healthcare system. We've been able to really see this approach bringing down the cost of HIV interventions because these systems are one and the same. So I think this also brings down the overall financial burden on the patient. One other thing that we're doing, I think, is the use of data-driven decision-making and planning, where we've seen different surveys and routine monitoring and evaluation informing us so that we can be able to allocate our resources to the places where they are really effective. I think one of the other big things that we've done together that has really helped is working with public, private sectors and civil societies. Just like you mentioned in the opening remarks, Rwanda works really well with the civil society organization. These people are able to mobilize funding, they're able to advocate for more funding. I think we saw them doing great things during the replenishment. So I think those are some of the strategies that we're using that are really helping us in Rwanda.
Thank you. Thank you so much for that. And what about efficiency, just the allocation of the resources? Are you finding that there is need to move resources around, or is it just really the integration that helps sort out efficiencies? I mean,
currently, yes, I think because of the integration and the fact that all these systems are one and the same, it is easy to move our resources around. We are lucky to have one of our biggest partners, the Global Fund, whose funding is flexible, the PEPFAR. So it is easy to move.
It's not because she's sitting next to you.
Not at all. So it's easy to move these resources around and allocate them there where we are seeing the greatest need based on our data.
All right. I'll come back to you with that question afterwards. If if I'm the health financing advisor to the Minister of Kenya, what would you say to me if you find that there's a lot of wastage in our investments? What can I do differently other than integration? Just think about it and come back and let me know afterwards. I'll come back.
Yes.
Let me go to you, Nolit. Yes? So, community engagement, he said that you engage very well with CSOs. And you're welcome to tell the truth. Community engagement and prevention are the core of HIV implementation, with the majority of initiatives being conceptualized and coordinated by CSOs. What domestic resource mechanisms and strategies are in place for response sustainability within the next 7 years or so as we push towards 2030? And what more would you like to see done?
Thank you very much. You said I tell the truth, so I'm going to tell the truth.
Okay.
Yeah.
Be nice, though.
Talking on the domestic resources mechanisms that are currently in place, we've heard from Dr. Gilbert that, of course, there are resources that the country allocates in different areas. For example, when we talk about allocation of the budget that is being put into the human resource for health, that's done domestically. There are some investments that the government puts there. The government again invests into the quality of healthcare services, and also the government has really done a great work in terms of making sure that the healthcare services are closer to the communities, and more especially for HIV, because that's the one now we are talking about now. So the services are decentralized and are closer to the communities. And we've got that chance and all those benefits through the government investment and also donors. Yeah.
So as a CSO, what has been your own role? How have you been engaged? And yeah, how do you engage with the delivery of services, or what is your role with that?
Yeah, as CSOs and communities, and more especially those who are infected or at high risk of HIV, we are fully engaged into the national planning, and currently we can say that the government of Rwanda has an HIV national strategic plan that is in place, which is also going to be used in the next 7 years. And then they are decentralized healthcare services. We are also involved into delivering services at the community level. And also then, as the strategy for the next years, the government has put in place the increased access and the use of HIV prevention services, where the local communities, like local authorities, the CSOs, and those people who are affected or infected by HIV are able to raise awareness, sensitize their fellows to come and access HIV prevention services. And then also, in terms of reducing stigma and discrimination, it's also there so that they can be able to access quality healthcare services. Talking also about delivery of minimum package of HIV services, engaging key population, adolescent girls and young women, and also people living with HIV.
Wonderful, great, thank you. It's good when the truth is truth. So, Dr. Veronica Mugisha, ICAP, in the face of declining fiscal environment, what do you think we can do more of in terms of health for money? How can we increase this and perhaps look at more value for what we have?
So, thank you very much. I think when we talk of the HIV, it is one of the typical examples of where we have to look at sustainability.
Sure.
Yeah, because the HIV program is one of the, I think, the one program that was heavily funded if you look back a couple of years ago. And that funding has been going down. So the question is, how do we ensure we maintain what we have achieved and even achieve more amidst declining resources? And while it does not rule out mobilizing more resources, but I'm going to concentrate today about efficiencies. How do we make the HIV program more efficient? How do we make sure it is cost effective and yet we maintain the quality of the services? So Rwanda is one of the countries that actually is doing well. We are moving very well towards the UNAIDS 95s. We have reached somewhere first 95 around 93 or 94%. How do we maintain that? And to do that, we need resources, definitely. Some of the resources, they don't depend on us. We have products, medication and antiretroviral drugs. We need tests. But we can reduce the cost related, for example, to testing by using efficient strategies. And this is what we have been doing in Rwanda. So instead of going out to test 3 million people to identify the 10 people who are not yet tested for HIV, we've been working with the RBC to come out with efficient testing strategies. You target. It is like, maybe if I could give an example, if you have a sack of hay, and you have 10,000 needles in there, and you need to find 1,000 needles. You'll get 10 people, and within an hour, they will have got you your 100 needles. Now, we have the same sack, but there are 5 needles. Those needles need to get out. How do we do that? If you bring 10 people to look out for those 5 needles, it will take a whole day. Inefficient use of resources. You can change strategy and you bring out a magnet and you put it in the sack, and then they will pull out the needles. So even for HIV, this is the way we are doing. Instead of conducting the traditional mass testing campaigns to identify 3-4 HIV positive people who need treatment, we've been doing targeted testing so that we reduce the unnecessary cost of unnecessary tests, because they take money. So that is one of the strategies. Another cost that has been coming in the HIV program is about the human resource. We have a lot of attrition and cost related to training, cost related to mentorship, because the HIV domain is evolving. New evidences come up, and the treatment regimes and the regimens have to change. Each time there is a change, the people at the periphery who look after the patients, they need to get updates. They need to get trained. And yet, if you train and they move away, then they leave a gap. So we have been working again with the ministry to see how do we do it efficiently. And that's where the COVID came in. The experience from COVID, we knew you can be in Kigali and you mentor people from the remote health facilities on how to manage. So working with the Rwanda Biomedical Center, Ministry of Health, so we are now moving whereby we don't have each time to move people from the national level to go around the 600 health facilities to supervise and mentor on new guidelines or treatment regimens, but a resource person in Kigali can be able to reach out to 300 people or even 400 people at the same time. He explains to them developments, changes, and advances. So it is efficient because in terms of reducing money, you don't have to spend money on transportation, venue hire, and so on. But also, the staff are remaining at their health facilities so that they continue providing the care. We are also working with the ministry. We have an e-learning platform. I hope all of you could have an opportunity. I would ask our colleague from the digitalization department maybe to share with you the link. So you can go in and you study at your pace. You follow the trainings, you even get a certificate for the professionals, you get CPD points. All these are a way of improving efficiencies, reduce the cost which people would have to spend moving from their sites to health facilities to go for training, but also they stay and they continue providing services, because the time actually, even when we do in-person training, you lose. Imagine somebody from somewhere in Rusizi coming for training in Kigali. You spend a whole day on the way coming for maybe a 3-day training, then you spend another day traveling back. That is a whole week out of the health facility. The patients don't have anybody to look after them. But by you following the training, maybe one afternoon, a week, while you are there, it means the services continue, your patients are treated while you are going treatment, the required information. So these are a way of improving efficiency while maintaining and actually possibly improving the quality. So these are some of the strategies.
Wonderful. Thank you. Thank you so much for your examples. Very useful. Calypso, Dr. Calypso, you were up here today, and the Global Fund has played such a significant role in many of our countries and continues to do so. And you have been instrumental in supporting the EAC with this ALM process. We've been with you, going from country to country, you know, following behind Shushu all over the places. We go to Mozambique, to different countries. What is the strategy to achieve these ALM targets? Because we know many countries are behind. They're barely 5%. Rwanda is an example, but other countries are very far behind. So what's the strategy?
Thank you. Well, that's a tough question. I also defer to my colleague, Shushu, who's been driving all this effort. It's very important. So Shushu, stay alert. But let me start, first of all, if I may. I just wanted to spend just a minute or two just to rehearse some numbers again. Okay. Apologies, I talk about numbers a lot. But then again, I head up health financing. So the Global Fund has invested a total of $1.74 billion in Rwanda to date, since we were set up in 2003. And over 1 billion of that has gone to the HIV response. And we will continue to do this. We hope we can continue for the time to come, though I take your point that sustainability is very important. And in the last grant cycle, over $100 million been allocated for the next 3 years to Rwanda for HIV. So, and we finance through the National Strategy Financing Model. So it's all flexible, as you mentioned, Dr. Gilbert, and that's quite important as well and appreciated, I think. And we can see the results. We can see the results that are very good across all 3 diseases. And as you mentioned, very close to reaching epidemic control effectively. But again, the question is, how do you sustain this? Indeed, that is the question. How is this sustained during the financial transition that inevitably will come at some point in time? The government is already the most significant funder of health and healthcare, though, of course, in areas such as HIV, external funders play an important role. And so that brings us to your question of what is the way forward? What does it all look like? So first of all, when we talk about sustainability, it's not just financial sustainability. So of course, financing is very important, but the issue is broader. So programmatic sustainability, for instance, looking at service coverage, at quality, the approach, the sort of patient-centered approach to care that allows people to have access, uninterrupted access to the life-saving treatments they need, and to do this free of stigma and discrimination. I think these are important things and are core elements of sustainability when we talk about sustainability. And then, of course, financial sustainability. Well, we at the Global Fund take sustainability seriously and financial sustainability. Our strategy, taking us all the way through to 2028, highlights financial sustainability as one of the 10 core shifts that we need to move towards. And we've seen also through the COVID crisis that it's absolutely critical that systems can sustain those, when they're under these shocks, can be able to effectively sustain financing and sustain delivery of services. And it's been difficult during COVID, of course. So financial sustainability for us, it's about very much aligned to the ALM agenda, more health for the money, more money for health, and the efficiency examples you mentioned are really important and real from the front line. So I think that's exactly what we're looking for, to understand and celebrate and scale. And then, of course, it's about the advocacy element, and this is what the ALM is about. And I will repeat again, because I mentioned earlier, it's evidence-informed advocacy. I think this is what makes the ALM effort really important. It's the legitimacy, it's the credibility under the AU umbrella, but it's also the focus on data, on evidence. So it's about the scorecard, for instance, looking at spending, benchmarking. It's about the tracker that looks a more granular way at the different elements of spending and looks at equity and distributional effects of spend and so on and so forth. I think that's really important. So I don't have a magic bullet, I don't have a magic answer, but I think I really firmly believe that being able to engage this way and continue the engagement, the dialogues are ongoing. They're not one-off events. They're ongoing efforts. And they're collaborative efforts, cross-sectoral, cross-country, multinational, and national. So continuing to do this and bringing the evidence to the table as we do this, I think, is the only way to sustain the response and the financing of the response, irrespective of what shocks come our way.
Yeah. Thank you so much. I appreciate that. Thank you. Thank you, Dr. Calypso, and for your $100 million this year. We should give Global Fund a round of applause, I think, for staying with us. I think to add to your financing sustainability, programming sustainability is political sustainability, and I think part of this conversation is really about that, and tomorrow we're going to have a little bit more discussions around the political sustainability, and I think we heard about the Kigali conference that's upcoming that I think will push further on that. Let me turn to you, Hind. So you're working here, and I understand that we've begun some discussions, or there's some proposals to build some kind of HIV sustainability roadmap. How is that working out, and how are you looking here as UNAIDS and the co-sponsor UN organizations to strengthen the domestic resource mobilization and leveraging current investments in Rwanda?
Thank you, Anne, and please don't mind my voice. I don't have COVID, but I'm recovering from a flu. Let me first try to frame where the HIV sustainability discussion is coming from a UNAIDS point of view. The Global AIDS strategy is what frames our work at country level, at global level. One of the 3 strategic priorities of the Global AIDS strategy is to fully fund and sustain HIV responses and to ensure integration of HIV in systems of health and social protection. So this is our departure point. UNAIDS at country level will be working very closely with the government to convene the partners, just as we're having this dialogue, to have a similar dialogue, specifically answering one question. What would be the transformations that need to happen for the HIV response in the context of Rwanda for a sustained and sustainable response? So that is the question that we will all, as stakeholders at country level, will have to deliberate and then come up with a menu of possible actions that fit the context of Rwanda. As UNAIDS, we're working, of course, with all co-sponsors, and I speak here not only of UNAIDS Secretariat, but I also speak of the UN system in general on HIV. So we're working together, and I think for this, for the preparation of this exercise, all agencies have been on board, providing input to it. I mean, I see UNICEF, UNFPA, WHO, and other colleagues. And so we're convening also the UN around this discussion. One thing we had discussed and agreed with Dr. Mohammed and Angeline and the rest of the planning team is that HIV sustainability discussion is not parallel or vertical or siloed from this broader health discussion. It's part of it. It's part of this broader discussion. So as much as we can integrate those discussions and dialogue, the better that we can do.
Yeah.
I have one point, and I think it's an unpopular opinion, but I'm going to say it anyway. And I do acknowledge Rwanda's big progress and achievements in reaching 95 ahead of the target dates even. But I think this achievement is just touching the surface. It's at the national level. If we look at the granular data, if we analyze the data at sub-national populations, we will see that the performance is not as good as the national data. For some populations, testing and treatment coverage is as low as 40%. We're talking 95% at national level, but 40%, at other groups and populations. So AIDS is not finished yet in Rwanda. It might not be visible, but it's not over. And that is more reason why the government of Rwanda needs to really look at how, beyond external funding, it can carry over this cost forward. Again, I refer to your example of cost of drugs. 230,000 people estimated to be living with HIV. That's one drug every single day for 230,000 people for the rest of their lives. So we can make the math and we can make the calculations, but I think the government, the country, the stakeholders need to start thinking of the transitioning. Sometimes the cost of success is very expensive. Because of reaching 95 and epidemic control, resources are being withheld back from the HIV program.
Yeah.
So this is just a note that I wanted to add.
No, thank you so much, Hind. Thank you, really appreciate that. It is true. We are in some ways victims of our own success. And the fact that we've done so well, lots of people are saying, is HIV still an issue? Is it something we need to worry about? Perhaps it's not the death threat that it used to be. But yet this year, 630,000 people died. So it still exists and it still requires that we pay attention to it. So I asked you in the beginning for rapid solutions. Can I see hands who would give us some suggestions? What is it that you think we could do to build up this sustaining the HIV response? I can call names, or I can call dress code, or table by row. Who has some ideas? Go ahead, Mohammed. Introduce yourself, please, as you speak.
Thank you very much.
You can also ask a question.
Yes, thank you very much, Madam Moderator. Good afternoon. My name is Mustafa Zakari, and I'm representing the African Union Commission. I would like to react to your question on the solution, and I think my reaction also touches based to some of the questions you have asked on implementing the ALM commitment. I think that's the solution. It's simple, right? Implementing the ALM commitment. But if you look at the ALM broadly, it has started in 2019, and it took us years to get in countries while the structure was transforming itself, adapting to the context, being refined, working with regional economic communities in the initial years, and now the ALM has reached full momentum to be where it is expected to be at member state level. So I think these dialogues themselves, if you look at them, is actually a huge milestone for a declaration that has started at head of state and government level. We have now national stakeholders actually taking it, owning it, and pushing it forward. I'm very happy today to hear that even artificial intelligence is being discussed under the ALM auspices. So I think I would agree with most of the speakers that this event should not be one-off event. We have to find a way to sustain the discussion and to sustain this kind of engagement. I'm happy to see that HIV is actually being brought into the discussion, which also means that we are leaving the verticalization issue. We are having HIV being streamlined within the broader health system strengthening agenda, which is also the agenda of the ALM. And it's very important, not only from the financing perspective, but also in terms of actually leadership and governance, ensuring that the key disease burden drivers like HIV, TB, and malaria are properly looked into with the right stakeholders, not only the finance ministers who give the money, but also at some point parliamentarians and private sectors who have key roles actually to play when it comes to the broader health financing, governance, and leadership. So to just cut it short, we just believe that if countries really maintain this momentum and make the dialogues regular, we would be happy somewhere along the line and look back and say we have ended, contributed, in establishing something that will sustain itself. I thank you.
Thank you. Thank you so much. Thank you from the AUC. Any other questions? Yes? Kindly introduce yourself and ask your question or offer your solution.
Thank you very much for the opportunity you've given me to speak, to say something here. My name is Dr. Perkapenda Ikeza, Planning General Director, coming from Burundi. Excuse me, I would like to speak in French. Madame Dr. Véronique, merci pour le partage des informations de la performance déjà atteinte au niveau de la prise en charge de la VIH-Sida. Félicitations pour
One
les efforts.
second, I need headphones. I know bits of French and it won't be enough. So if you say anything serious, and for the speakers so that they can all participate.
Have fun.
Okay?
Je disais que je vous remercie pour l'opportunité que vous me faites pour pouvoir m'exprimer. Je m'appelle Dr. Porekapendayi Keza, directeur général de la planification au ministère de la Santé au Burundi. J'ai suivi avec intérêt la présentation, bien tout simplement le partage des informations fournies par le Dr. Véronique en rapport avec le programme de la prise en charge des VIH-Sida ici au Rwanda. Félicitations pour la performance déjà atteinte, mais qui a bien sûr eu un coût. Lorsque nous parlons de la prise en charge de ces grands problèmes de santé, dont le VIH-Sida, le paludisme, la TB, la tuberculose, nous voyons que dans beaucoup de pays en Afrique, ou les pays en voie de développement, beaucoup des interventions sont généralement soutenues par le Fonds mondial, Global Fund. J'ai vu dans les présentations de l'avant-midi que le Rwanda vraiment est un pays à féliciter. C'est une bonne école qui a fait des efforts dans la réduction de la dépendance des financements extérieurs lorsqu'on compare avec les autres pays. Je voudrais savoir, Madame Dr. Véronique, si, de façon spécifique, en matière de prise en charge du VIH-Sida ici au Rwanda, est-ce qu'il n'y a pas des efforts à fournir pour la mobilisation domestique, pour être proactive avec des événements qui se font au niveau mondial, une fois qu'il y ait peut-être réduction des financements, que le Rwanda ne puisse pas retourner, ou bien peut-être la performance qu'elle a aujourd'hui. Ça, c'était la première inquiétude. La deuxième interrogation que je voudrais que vous me donniez un peu d'éclaircissement, madame. Vous avez parlé de performance. Oui, c'est un agenda mondial 2030 avec 16 objectifs. Nous savons que le troisième objectif, qui parle de la santé, avec la couverture santé universelle, les interventions dans le domaine de VIH-Sida sont dominées par le public, les interventions publiques, mais également le privé, les associations, mais qui sont engagées. Mais il y a, madame, dans nos pays, un secteur privé qui n'est pas négligé parce qu'il y a une proportion, je sais, probablement même ici au Rwanda, qui consulte directement les structures privées. Il y en a même qui ont des performances de qualité de prestation qui peuvent même être égales ou supérieures à celles publiques. Je voudrais savoir si vous avez des interventions, des aides, parce que le privé, oui, bien qu'il travaille dans le social, il a également un but lucratif. Parce qu'il y a des fonds que le privé a mis dans ces interventions. Est-ce que dans les intras, ou bien les autres interventions, la formation des ressources humaines, qui sont subventionnées probablement par des partenaires au développement, le Global Fund, est-ce que vous associez également le privé pour que nous soyons caractérisés par l'équité? Une maman qui est enceinte, qui va consulter directement le privé, nous sommes dans la PTM, la prévention de la transmission de l'enfant, est-ce qu'elle les reçoit équitablement comme celle qui vend dans le public, les interventions en rapport avec la prévention de la transmission de l'enfant? Parce que nous ne pouvons pas éradiquer le VIH-Sida d'ici 2030 si toutes les stratégies dont le diagnostic est pris, dont le diagnostic et le traitement à test and treat. Je voudrais des éclaircissements en rapport avec la collaboration avec le secteur privé. Je vous remercie.
Okay, thank you so much. I believe that that this ALM dialogue is coming to you next in Burundi, so you can go deep there and let's see how things are going as well. So, if I could take one more question, if there's one question, yes, and then I'm going to come back and we'll just wrap up.
Thank you very much. Thank you very much. I don't know why it's not working. I just followed up with interest the discussion of Dr. Veronica, and she mentioned that there is strategic targeting testing, and so that we don't misuse resources. I'm going to talk about much on prevention, especially of new infections. It's true that we have just prevention of new infections, and we are looking at specific services that we can help us to use our resources effectively. My concern is now, when you look at the issue of teen pregnancies in the country, which is increasing, and where there is pregnancy, there is infection. So sometimes we limit ourselves to look at the pregnancies, but we don't go deeper. If there is where there is pregnancy, probably there are other infections with the hepatitis B, HIV, and the rest. And again, when we look at the trend with the teen pregnancies these days, we see that not only there are a range of 14 to 17, which is increasing in number. And yet, as you know, by legal, the law of Rwanda, we have services, we have structures in place, we have youth corners, but these people are not allowed to use the contraceptives, which definitely expose them to pregnancies. But we don't going to limit ourselves to see these teen pregnancies. We know that where there's a pregnancy, there are a lot to see. Yeah. So for the benefit of minimizing new infections, what is the role of, we know that the civil society has been doing something. We know that there is a movement, they went to parliament, there is a process that was going on. But what is the role of ICAP or the rest of organization that to lobby for the age consent, for the adoption of the reduction of the age, to cover these young who are sexually active, though the culture is not allowed, but what is your effort? What is do you believe can be done for the purposes of reducing new infections? Thank you.
Thank you so much. I will also use this opportunity, panelists, to give you a last comment across any of the questions. I'll just literally just come through and give you a chance to respond, because I think some of the questions, even though they're targeted, are relevant to others. So if I can come back to you, Nolit, since we're here, let me get a sense of your own answers. And I think that last question is one that I'm sure you're itching to answer as well. So let's hear from you.
Thank you very much. Like my sister has mentioned, yes, there is still a problem around the access of services to the minors. That means the under 18, and more especially when you're talking about HIV, we come to the adolescent girls and young women, because we know that women are the ones who carry pregnancies, though there is someone who contributed to that, who is a man. Yeah, the reproductive health law, of course, has some provisions that don't allow them to access services. But as a movement of civil society, Rwanda Angels Forum has 139 national NGOs. We've been engaged in 2 different advocacy. We have been conducting dialogues in the parliament and with the different stakeholders, and also making sure that the adolescent girls and young women are also equipped with skills, information, and then they are able also to advocate for their own issues. Because when you're talking about HIV linked to an adolescent girl and young woman, and then someone else who is 30 years or 35 is coming to a dialogue like this one, and start talking about the issues of that girl when that girl is not there. So as civil society organizations, we've been really investing in capacity building, making sure that they are equipped with the information as the dialogue continues, because Rwanda provides a space for discussion. So the discussion is ongoing, and it's not only that law. There is also the medical rehabilitation insurance law that is also requesting a consent from a parent to a child who comes for services. Yes, we are still seeing the young people coming for HIV testing, but if we are to implement those policies or those laws, I don't think doctors would provide those services. So we need to make sure that those policies or those laws are amended and providing a conducive environment. So I call everyone in this room to join the hands with us so that we can make sure that the laws are really providing a conducive environment for the young people. But for other services related to treatment, they are getting those services because Rwanda has already adopted the test and treat, and also the continuum HIV care, where we do testing and then link those who are tested for pre-ART care, and then after they are enrolled on ART, on care and treatment, and then we make sure that also their viral load is, they are suppressing the viral loads. Yeah, thank you.
Thank you so much. Dr. Veronica, while we're on this one, since it's linked.
Okay, thank you. So the Rwandan law defines majority age depending on what it is about, either 18 or 21. So however, in spite of that law, there are guidelines, the medical guidelines. For example, for HIV testing, care and treatment, any child above 12 years does not require parental consent to be tested for HIV and to be treated. That is part of the technical guidance from the Ministry of Health to facilitate access to HIV services. So as the advocates for the law changes continue, at least we know up to 12 years a child can access HIV services without the consent of the parent, which is something very good and which is positive. Of course, it would be better with the law supporting that. But also, one of the things I always bring up when we talk of the law, of family planning and so on, the risk of HIV and pregnancy are transmitted through the same route. Yeah. But the risk of HIV is greater than pregnancy. Pregnancy, you get pregnant once a month, and once you are pregnant, you can't get pregnant again. HIV, you can get HIV at every exposure, which makes the risk even higher. So that's why I think we, public health specialists, when you are talking about HIV, we had to lobby so much so that these children could have access regardless of whether they are not allowed to have sex or they are not allowed to use family planning. And of course, we will continue lobbying for the rest, but at least we know up to that age they have access to the services. Alors, en rapport avec mon collègue provenant de Burundi, il a demandé le niveau de financement local attribué au programme de lutte contre le VIH au Rwanda. Malheureusement, je n'ai pas une bonne situation à répondre à votre question. Je vais rapporter ça peut-être à mon collègue, le docteur Biraro. Je ne représente pas le gouvernement. Mais ce que je sais que nous travaillons ensemble pour rendre nos services plus efficaces. Par exemple, pour le testing, nous ne faisons pas le testing au hasard. Donc, nous utilisons les données, nous analysons les données, comme ça nous savons qui est à plus haut risque. Par exemple, les hommes qui ont des rapports sexuels avec d'autres hommes, ils sont à plus risque. Nous avons les adolescents. Donc, à partir des données, c'est là où nous remettons les ressources pour le testing. Et puis, à partir de ça, on trouve que nous avons ce qu'on appelle le niveau en anglais, on appelle ça yield rate, ou le niveau de positivité. Donc, au lieu de prendre, comme j'ai dit au départ, au lieu de faire 3 millions de tests pour récupérer seulement 10 personnes positives, nous pourrons tester 300 personnes pour récupérer 10 personnes séropositives. C'est ça que nous sommes en train de faire. Aussi, même pour la prise en charge, nous savons les populations qui sont marginalisées. Par exemple, les hommes, vous les hommes, vous avez l'habitude de ne pas utiliser bien les services de santé. Donc, nous sommes même en train de discuter comment peut-être nous pourrons utiliser les hommes pour toucher leurs collègues, pour les ramener au service de soins. En termes même d'adhérence, de suppression virale, les hommes ont une plus mauvaise
performance à la pas avec les femmes. Nous sommes en train d'utiliser les données pour voir comment nous pourrons faire ce qu'on appelle le targeted testing ou les interventions focalisées pour les groupes à haut risque, à plus risque que les autres. C'est ça que nous sommes en train de faire ensemble avec le ministère de la Santé.
Thank you, thank you, thank you, thank you, thank you, thank you. Thank you. Let me invite Dr. Gilbert to follow on that and really just perhaps a question that the gentleman from Burundi was asking was also linked to the role of NGOs in, I mean, I think you used the term private, but I think private can also be non-governmental. And so really in answering that, we have been having meetings with your government and your countries about social contracting of non-governmental organizations to be able to deliver services. So maybe as you answer that question, you can also include the issue of social contracting and whether that's something that you're considering in terms of greater efficiencies and more money.
Yes, thank you so
more
much.
Value for money, yeah.
Like I mentioned in my discussion before, so here in Rwanda, we have developed a really strong collaboration with, be it the public, creating public-private partnerships, but also greater involvement of the community as well as the civil societies in responding to the HIV epidemics. So we know, for example, at the Ministry of Health and Rwanda Biomedical Center, there are some programs, especially around prevention, impact and social mitigation, social marketing of condoms, lubricants for the MSMs, which are implemented by the civil societies. Even during our grant proposals, we already put the civil societies to implement on behalf of the government. So this means that, of course, we have all these legal frameworks and collaborative frameworks that are put in place for monitoring, efficiency and effectiveness and alignment to our overall NSP, which we shouldn't miss. I can also say maybe in line with that, in RBC, we are trying as much as possible to work on all these, like Dr. Veronique mentioned, implementing or increasing, like I can say, new service delivery models, like the case-based surveillance, as well as integrating especially digital health technologies. So there are some of the things that we are looking at implementing in RBC along the, other innovations. Hopefully at a certain time with this greater involvement of the civil societies, we shall get to other innovations like community-based testing and self-testing, which is already being implemented here in Rwanda. I think one of the other things that we must focus on is also, in general, if we want to achieve more, we've seen a lot of gender inequalities, gender disparities, prevalence rates between men and women. And I think we've also seen increasing rates, adolescent young girls and women. So these are some of the things that we must focus on. If we want to achieve, our control and sustain the gains, we have to really focus on these high-risk groups, the MSMs, the female sex workers, as well as addressing these gender inequalities. And then lastly, maybe using the optimally our resources. The resources are going down each and every time, so that's why we need more, data-driven decision-making and planning, more involvement of private sector and the civil society so that we can all drive these gains together. Thank you.
Excellent, thank you so much. Hind?
Yes, can I pick up on the point on social contracting?
Sure.
Because I think it's very important as the country is transitioning towards domestic resource mobilization to really have that dialogue at some point of time. There's been a lot of investment on civil society in the country, and Nuliet already mentioned a lot of the good things that they've done for HIV, but also for COVID, building on the investments that were made on this community systems for HIV. But as we transition, and most of these resources have been from Global Fund and PEPFAR, supporting the communities to lead responses, to monitor, services, quality, accessibility, and availability. But as we move to domestic resource financing, that may be a little bit threatened, the engagement of the community. So we really need to make sure we don't lose that momentum and that capacity of communities on the ground as we shift to domestic financing. So social contracting is a strategy to still continue to use the communities to deliver services on HIV prevention, on monitoring the quality of services, and so on. So while we shift from external to local resources, we still need to make sure that we're protecting the communities that we've invested in for years and years and millions of dollars. Thanks.
Wonderful, thank you. Thank you so much. So, Calypso, last word in response to several questions that were thrown out or comments that were thrown out, but really just, what's your last word on how to make sure that we're sustaining this HIV financing?
Well, perhaps I touch on what my colleague Mustafa mentioned at the beginning, that the answer is this. We continue having the conversations, bringing the information to the table, having those debates, raising those issues, and then updating one another. So this has to be an ongoing effort. And I just want to, I remember, I think it was it here, a few months ago, when I think it was Dr. Kabaruka, before he stepped down as the chair of the board of the Global Fund, he talked about the demographic dividend, how the imperative, having such a youthful population in Africa, in Rwanda, it's a necessity to invest in health and education. There's no other way. So the times are tough, but it's really a one-way street. So if we think about this, that we have to do it, then we'll find a way for doing it. Thank you.
Thank you so much. And that's it, colleagues. I think this has been a really rich conversation. I really tried to catch us before 5 o'clock, but we're over by like a minute. But I'm sure I'll get creds for that, for just 1 minute over time. But just to wrap up by saying that we've heard some key takeaways that I think we need to take back with us. That we have to continue to focus on how we integrate services and how we improve those services. But I think as we integrate those services, we have to be able to look at what Hind talked about and about investing in the different regions. Where are the most vulnerable regions, so that we're not making investments equally across the country, but rather identifying where we have the greatest vulnerabilities and who are the most vulnerable, so that we're also targeting the populations that need the greatest investment. I think we've had a really rich conversation about efficiencies and innovations in financing, and we know that there are just how you allocate the resources and how you leverage it. From the examples that we heard from both Nolita and Dr. Veronica, I think are really, really exciting ideas that need to be scaled and implemented as a way of working across the board in the health systems that we have. I think the idea of social contracting is a strong one, and we talked about that, and we are seeing countries really, really producing amazing results with this. And then there's the inequalities and the gaps that we need to focus our attention on, and your point about prevention. If we don't focus on prevention, our numbers continue to increase. So we can raise as much resources we can to sustain the current people on treatment, the 230,000 people, but then by the end of the year, we're at 250,000, and then the next year it's another number. And so we have to be able to check it. And it's the girls and women and young women that are highly vulnerable and the key populations. And I think also really being able to pay attention to these complex, difficult conversations around sexual reproductive health rights and services are complex, but they're necessary. And we have to be able to have those conversations if we're going to really break through, I think, all of this. And so just to wrap up, thank you so much for paying attention to this, and hopefully you'll get some guidance on the next step and how we wrap up this session. But just to say that there has been a mention of, in raising domestic resources, what does that mean? Does it mean that we're raising the resources because there's a gap in international resources or external resources? And I think the point is no. And I think that the point that Dr. Calypso made earlier is that the Global Fund is still with us. We're walking together on a long journey. And so it's really about how do we make sure that we're building a sustainability roadmap that helps us to prepare for the direction that we're taking, but also then be able to put resources into other more valuable, not more valuable, but other areas that need the focus. So really this is the objective of us raising these resources and making sure that we can do way more with less. Thank you. Congratulations and big claps for the audience, for the panelists, and to each of you. Thank you. Okay, you can get down. I tried.
Let's appreciate them one more time. Thank you. Thank you very much. I think Anne will continue our conversation of your life as a media personality and anchor. I see the presence and the command. Well done. Let's appreciate her again and the rest of the panelists on that session. Wonderfully done. I want us to jump real quick on the final panel for the day, and we'll call it a day. And that panel is going to be focusing on promoting health equity and access through encouraging private sector investment in the healthcare sector. This panel is going to be moderated by Pierre Harerimana, the CEO of Rwanda Medical Supply. Let's appreciate him as he comes. Is he in the room? Yes, let's appreciate him as he comes. We can put some more energy. It's the final panel. And so we say finishing power.
Okay, hi everyone. It's hard to moderate this session when people have set their mind that the session would end at 5, but we try to be as brief as possible to make sure that you also, those who have to enjoy our Kigali, have to also enjoy the benefits that Kigali is providing. So allow me to introduce myself. I'm Pai Harerimana, CEO of Rwanda Medical Supply. It's a state-owned company that is mandated to procure, warehouse, and distribute health commodities to public health facilities. So allow me to introduce the panelists. We have Ms. Noela Bigirimana, Deputy Director General, Rwanda Biomedical Center. We also have Mr. Calixte Kanamugire, Deputy Chief Executive Officer, Private Sector Federation. Is he in the building? Okay. We also have Enoch Rwamuza, Health Financing Senior Advisor, Technical Advisor, USAID IREME. So these are the panelists we have. You've been hearing people talking about private sector engagement. It's now time to dive into that section. We hear from our panelists in details how to engage them, the benefits, and also the efforts from private sector federation. Without taking much of your time, I want to start asking Ms. Noela, PDGRBC, with your understanding of the role of private sector investment in healthcare service delivery, what major steps have you taken to ensure that investment is realized? Just be brief and precise. We want to leave this, we want to, to be brief and give some space to these people to also do other activities after this session. Thank you.
Are you saying we want to leave now, or we just take a few?
No. I want
minutes?
you to be brief and precise. Thank you.
It's true. So we want to leave some time for networking. But I think I want to start with thanking everyone in the room, because we've had some very important conversations. I hope we don't leave them here when we go back to our work. They are too important to leave in this room. So one of the things I wanted to start by acknowledging is, I think as part of this national dialogue, of course, we are focused on Rwanda. But Rwanda is also in a place where, and it's a journey, right? And I want to start with that, to acknowledge that there's much to do, but we are here to reflect on what's been achieved and on the challenges. As government and as government entity, we know that we cannot do everything alone. And it's so important to realize the role of the private sector and the nonprofit or for-purpose sector. I wanted to say that one of the things that we've done as RBC on behalf of the Ministry of Health is to engage the private sector. And it's in times of crisis usually that you find your friends. And the private sector, if we just take a screenshot of the role that they've had when we were fighting a pandemic, I think it gives you an idea of their involvement from the beginning. So we know that these are companies, these are private foundations. It's also philanthropies or high net worth individuals. And so during the pandemic, some of the opportunities that we saw, we were able to have more impactful interventions. We were able to raise more resources. We were able to raise or to be able to deploy innovative solutions through and with the contribution of the private sector. So in terms of the types of contribution, we've seen financial resources. I think that's what we all look at, but it's not the only way. There's also in-kind support. One example, we worked with telecom companies to raise awareness and in behavior change during the COVID-19 pandemic. But it's also, as I said, a screenshot of the continued engagement that the sector has had. In terms of when we usually, to your point about how we've been able to engage them and take it to our collaboration to fruition, it's also the way we discuss. It is an equity argument, but it's also an imperative and a business argument. When you speak to the private sector, it's important as part of the sustainability to draw the line with there is an increase. We know there's an increase in healthcare services. We know that as Rwanda, we have dedicated growth and investment strategies. RDB works closely with all of us across sectors, including our healthcare sector. We know that there is high potential for the private sector to support community service as well as specialty care. So the private sector has come along from these very crucial moments like crisis, but also in time of not when you're in crisis, but all the achievements we've been on stage highlighting and all the challenges that we've talked about. Think of us as a co-driver in these endeavors. So maybe I'll stop there. We're not maybe as good as at documenting the role that our partners, both from private sector and nonprofit, are doing, but we want to appreciate it, and it's still a journey, but we are together on that journey.
Any challenge have you ever faced?
There are many challenges. Put simply, the demands are high, the resources are low. That's one challenge that we continue to face. I think from the previous panel, we heard about some changes that are ongoing in terms of the policies and guidelines. These are challenges that we are happy to take on. And so just like anything, we work in a complex sector. I think it's safe to say. It's both a social sector, but it's also an industry. And here you are working with infectious diseases, but also
having to tackle chronic condition in the midst of pandemic alerts all the time, in the midst of, as we heard, the health sector, when you put it in the context of social determinants of health, you realize that the challenges are broader than just the sector that we talked about. But it is a complex sector, and so by that virtue, there are challenges that we face, but we face them together.
Okay, thank you very much. Mr. Calist, you are here representing Private Sector Federation. So tell us efforts in place to continue investing in health sector, and also how this contributes to the health equity agenda.
Thank you. The Private Sector Federation is an umbrella organization comprising or representing all the business community in Rwanda. It operates under 76 professional associations, including the Association of Pharmacists and the Association of Private hospitals and clinics, what we can call private facilities, health facilities, among others. We have done a lot by mobilizing the business community to increase the investment in the health sector by two ways. First, increasing the way of mobilizing funds to support government programs when necessary, where community health insurance, and some other programs like IRCAD, which we have been mobilizing business operators last year, and it went well. But also we do mobilize foreign investors as they come to invest in other sectors like in industry and in services and agriculture. We mobilize them to invest also in health facilities. To date, we have both national, public, private investors in health facilities. And I have seen the owner of the facilities here, some hospitals, private hospitals, which are working well. And we have also foreigners who have invested in the sector. And they are also contributing a huge performance in the sector. Probably, especially, I say, in the specialized service provision, like eye services, dentistry, and the other services, health services. They are doing well, and their contribution is very, very appreciated. To date, we have 300 and, just speaking about the numbers, we have 330 health facilities employing each one at least one doctor, what is good for the country. And we have also put in place in our organogram, internal organization, a health program unity dealing with these diseases like TB, malaria, and so on, and the AIDS, just to mobilize our maybe truck drivers and the others to be aware of the problem of not taking care of their health. We have also worked with the different public institutions because we have a program for public-private dialogue. This program helps us to deal with issues which are arising in different business sector. When they have a problem, we call the meeting, the public-private meeting, and we try to find a solution for that arising problem or arising issues. This is the reason why we appreciate this meeting, this dialogue on health financing health sector, because private financing health sector, because we think that it can also help us or Rwandans to make a next stage in terms of increasing the financing of the health facilities and health services in our country. I think that is what we are doing. And we know that there is some challenges. Yes, they cannot, everywhere we have challenges, but we have a way to deal with those challenges when they are arising. Yes, thank you.
Okay, thank you very much. We are here with different partners. What can you request to them?
These partners?
Yes.
Okay, only one thing. One thing, the partnership. We want to work together with them to overcome the challenges which we can face. Only that. Okay. We want to raise their willingness, their goodwill to work with the private sector. And the private sector is ready to offer its contribution.
Okay, thank you very much, Mr. Enoch. Coming from one of the key partners in health sector, I would like to know your role in ensuring that private sector investment is secured in health sector.
Yeah. Thank you so much. So, as you rightly mentioned, USAID, we're working with one of the USAID being one of the biggest donors in the sector. So I will be speaking from a perspective of an implementer and what we have done in the sector to really encourage private sector investment in health. So I think I will talk about three things. The first thing is that we've seen that COVID has demonstrated that the health sector is an essential service. That is without question. So one of the things that we do is producing evidence to really ensure that the private sector fosters the stewardship as a complementary sector to the government or public services. So in producing evidence, what we've done is, for instance, we've produced in collaboration with MOH, RDB, CHAI and other partners, the Private Sector Engagement Master Guide, which is a document that really outlines some of the investments in the sector or where opportunities can be found if you want to invest in the health sector. That document can be found on the MOH website, and it really talks about the opportunities but also delves deep into the processes. For instance, if you want to start a manufacturing plant or if you want to venture into diagnostics, what are the processes? Especially, I think a lot of because the sector is, it has a lot of regulations, a lot of things that you have to put in place before you start operation. So we tried to summarize all those opportunities, and within each opportunity, we tried to give you a step-by-step process of whoever wants to invest. So that's producing evidence, especially for those investors who are coming to the sector. The second thing is fostering dialogue. So we've been heavily involved in really operationalizing the private sector engagement core team. This is a core team that really brings the Ministry of Health, the private actors, to really discuss about the challenges that are faced. But within that, sometimes we even go further to really bring together private sector actors that are on different sides. For instance, I'll give you some numbers after engaging, because one of the challenges that the private sector will tell you, it always revolves around tariffs that haven't been updated. I think it's a point that was raised in the morning, but also there is limited access to financing. So what we've seen, we've conducted different surveys, and you see that interests are very high, especially when you want to borrow in the sector, 16 to 21% on average. And here I'm speaking specifically on service provision or private facilities. And then you find that even when you get those loans that are really necessary, the most popular loans in the sector, in the private provision, especially private providers, you find it's invoice discounting and overdraft, those are types of loans that really kick in when you're under pressure to pay your operations or your staff. So those are not the types of loans that are going to really advance your operations. So basically what we've seen is that the banks or the lending institutions haven't really taken up opportunities that exist in the health sector. Part of it, we also asked some of the lending institutions, and you find that they don't understand, or they have a limited understanding of the sector. We've seen that the sector is complex. There is different challenges like delayed in reimbursements. So if they lend to someone and they are not paying on time, they take them as a risky client, but that money will come eventually, but it's just because of delayed in payments. So we then tried to work with those banks. I think we've worked with 3 lending institutions to develop tailored loan products for the health sector, which we bring the banks and the private provider into the same table to really discuss some of this and develop these tailored loan products. Lastly, to talk about equity, since we're discussing investment in health, but also fostering equity, I think here I would say that one of the other challenge, so in Rwanda, we know that CBHI is the biggest scheme that covers the majority of the population. So you find that the market that remains for the private sector is private health insurance and out-of-pocket spending. So RSSB, we've worked with them to really, they have taken bold decisions to really engage the private sector in expanding access to their members. So we've seen, for example, what they've done with MediHeal, where imaging services can be accessed with the CBHI insurance to reduce the long queues at the public facilities. So we are continue to working with them to really negotiate with other private providers so that they can also be contracted with CBHI. So lastly, I would really urge the private sector to see, as the CEO of SFH said in the morning, there is money in the health sector. So some of these contracts that we have with CBHI heavily located in Kigali. So finding ways to explore other urban cities like secondary cities would be an opportunity. And I think with the example of MediHeal and other initiative to really engage the private sector, there is a lot of opportunities even outside of Kigali. I will close there, and yeah, that is what I wanted to say on that. Thank you.
Yeah, thank you very much. At least now we can understand that partners are also there to support private sector. I don't know if there is any question in the audience, like 1 to 2 questions or contributions before we wrap up. Yes?
Thank you so much. I'm Emmanuel Mazimhaka. I'm the head of communications, fundraising, and humanitarian diplomacy department in Rwanda Red Cross. Mine is not a question, it's just a contribution. As the representative of the private sector federation mentioned, there is a need to have a good cooperation with the private sector federation. And having a good cooperation with the private sector federation is contributing to building the country. Let me give you some examples of the contribution of Rwanda Red Cross during the pandemic COVID-19 pandemic. Rwanda Red Cross contributed in the evacuation of people affected by COVID-19 pandemic through our ambulances, meaning that that was one of the contribution to support the Ministry of Health through a memorandum of understanding which was signed between Rwanda Red Cross and the Ministry of Health. So again, for example, during the pandemic, Rwanda Red Cross constructed different hand washing facilities in different public areas. Example, in markets, in schools, and so on. So we also mobilize people with our volunteers deployed in different districts. So those are some of examples from which we can contribute, all of us here, to even increase domestic resources for health. That's why this is one of the tasks we all have to build our nations. Thank you.
Thank you very much. Panelists, anything that you can also, again, let the audience know, starting in less than 2 minutes.
Okay, thank you. The last word I can say here in this forum, I think we'd like to raise the idea of collaboration, as I've said, but in a strategic way. Having maybe a body where a government institution can be part of the body, a private sector can be part, and the civil society be part, even the development partners be part of the body. That body should, first of all, deal with a strategic plan for public, private health financing strategy. With that strategy, I think we have to deal with issues of de-risking investment in the health sector, because it is very, very difficult to pay back the loan from heavy investment done by our private investors in that sector. They can also deal with some issues when we want to get document certification to speed up the business establishment and the operations. Sometimes we can face some difficulties. That body should help to speed up all the certification issues. I think even the issue of tariff between both are our members. Private health facilities and the insurance companies are our members. But sometimes working for profit, both of them, but in different ways. Sometimes they don't understand each other and collaborate as efficiently and effectively. I think that body can also deal with that issue. Then the body is very, very useful. The strategy plan for that body is very, very important if we want really to address and unlock all the problems we face in the private investment in the health facilities. Thank you.
Thank you, Noella.
Thank you. Maybe I wasn't surprised there were not questions because everyone wants to leave. But I think to continue the conversation outside, maybe I want to just mention two important points. So we've heard of sort of the return on investment argument that we just heard, right? So around the private sector engagement, how do we incentivize the investment? How do we de-risk the investments? So that's one argument, and I think it's an important one. There's also another equity argument, which maybe we didn't have time to talk about here, but we've come around it through various panels here, there's the access that we have to increase, there's the affordability that we have to maintain, and then there's keeping the most vulnerable at the core of all of our services. There's also a last argument that I want to mention, which is an imperative one. If we say that we want sustainability and we want a sustainability roadmap, it's one that shows diversification in terms of resources, in terms of sources of funding, in terms of support. So that's another argument that actually brings us all together, right? So we don't say there's for profit or there's not for profit. Ultimately, we are all for purpose, and that's the one purpose that we want. If we've all agreed on that, it doesn't matter what the background is. That's what we work towards, and I hope that the national dialogue that we've had around health financing is helping us move closer to there from these multiple perspectives.
Okay, thank you very much. Yes, Enoch?
Yeah, so mine will be brief. So our major role as development partners is really to think with you as the private sector to demystify the health sector, especially for those who are venturing into the sector for the first time. So our doors are open and we're here to really make that linkage. And lastly, I would urge the private sector to really think of the challenges that exist in the health sector as opportunities. And if you see them as opportunities, I think with your innovation, we can really do wonders in terms of advancing equity, but also making or getting returns on our investments. Thank you.
Okay, thank you very much. To wrap up, as you've seen, the last one. Okay, good. Thank you.
Good afternoon, everybody. My name is Dr. Nyengwaya Jean from the La Croix du Sud Hospital. So, what I want to say is, they used to say for profit. Private is for profit. No, private is for to sustainability. Because in the private, what I would like for everybody, and also for the public, to understand what is it. We have the money we get is to sustain our activity and to improve our activity. This is the problem we have. Because we can say, we are in the private sector, but I think we can say for so-called private. Because when the money received just permit you to sustain your activity. And, but I think if it can be possible to explain, we need a lot of, what I can say, some ambassador to explain really what is the problem with the private sector. Because medicine, if we want to make performance, because with the discussion we had today, we saw that more and more, we need more and more good equipment. We need more skilled doctors. We need more and more. But to get these things, we need a lot of money. And if in the logic is to reduce money, how can we make progress? It's what I want to, and it's why I'm very happy with Mr. Calixt, but we can help us also to be our ambassador. And the last question I want to raise, I want to tell the representative of the Minister of Health in Burundi, but we can discuss after and explain how we are working with the Minister of Health to assure treatment and following of HIV patients. Thanks a lot.
Okay, thank you very much. What I've heard from you is that private sector has money, so let's take advantage and use that money to continue investing in the health
Exactly.
sector. Yeah, to wrap up, I may say that, of course, we need the private sector to continue improving our health sector. And what I'm proud of is that our government is aware of that partnership. And as you've heard from the panelists, some improvements have been made, and we just say, let's continue engaging the private sector so that our health sector can really be strong to overcome any barrier that can come along the way. So thank you very much for attending this session with the mindset outside. And thank you for panelists. You really made us, at least we've understood the role of private sector. Thank you very much. Round of applause to the panelists. And to yourselves also for being attentive. Thank you.
On behalf of everybody, I want to assure the moderator that we were here. Don't worry, we got every point and all the panelists. And I always say the conversations are never meant to end. It cannot end on these panels. The panels are just conversation starters. And then we need to continue having these bold conversations moving forward. Now, we've had a lot today. And of course, that panel is what brings the curtains down for day one of this very, very important dialogue. And I think we have had several important statements, and one of them was the focus should be in looking at how to integrate services, and of course the fact that AI technology is going or is already becoming a game changer in this sector. And of course, I've heard also from this particular session that the private sector is ready to offer its contribution, and that the perception of private sector being there for profit is something that needs to be debunked. They are there for sustainability, to sustain the services that they offer. And oh my God, Dr. Veronica, I need classes. The French classes. I think I'll become more competitive with that level of French. So I want us to bring down the curtains to this event today, but I want to remind us that tomorrow we have a very packed panel. That panel is comprising of two senior government officials. We have the Honorable Dr. Sabe Nsanzimana, who's the Minister of Health, and we'll also be having the Honorable Janine Munyanshuri, who's the Minister of State in charge of Public Investment and Resource Mobilization at the Ministry of Finance and Economic Planning. And we'll also be able to have Professor Sene Fiseha, who's the Vice President, Global Programs at the Susan Thompson Buffett Foundation, and Dr. Irene Isaka, Director, Social Sectors, East African Community, and of course, Mrs. Anna Bodipo, the Director of USAID Rwanda Health Office, will also be on this panel. And I want us to prepare ourselves to have very honest conversations. I think we need to shift from seeing this as a beauty contest of sorts, of who's the most beautiful in terms of who's doing more than the other, and now shift to what do we need to collectively do together to fix where the problem is. And I believe with that we'll be able to achieve the theme of this forum. Otherwise, if we leave here just saying how good we are and how the others are not, then we'll miss the point. And I'm here to support in coordinating us back kumurongo. All right? So thank you so much. It's been hectic, and I want us to leave and be able to relax and be able to prepare for tomorrow. We'll be here by 9 a.m. We have to start at 9 a.m. When you give us prescriptions, you tell us and insist 3 times a day. In the morning, after breakfast, at lunch, and at night. So we must also observe time in terms of the prescription of the program. So please let us be able to follow that tomorrow when we come. So I have no much to say, but to thank you all for the patience and the cooperation. In case there's any area that things did not go as per your expectation, one more time on behalf of the organizers, I want to make an apology. And I want to appreciate those people who have been speaking in your ears, sometimes even when you're not listening. The translators, they do an amazing job, and they're usually unsung heroes. Thank you very much. So, live from Serena, I want to say that it's been great, and I'll see you again tomorrow. As always, my name is Eugene Anangwe. Signing off. Goodbye.